طيب الobjectives من المحاضرة هذه. Identify the most common cause of death due to traumatic injuries. Summarize some of the components of the scene size up. We know scene size up is the first process we do in the trauma assessment. So we'll summarize that and describe the role of the scene size up in provider safety and patient injury. Explain the relationship between the trauma or the kinetics of trauma and the trauma severity. And also identify 3 collisions associated with the motor vehicle collisions and how vehicle safety mechanism affect or anticipated trauma patterns. We'll talk about factors, predict type of severity of injury due to fall, describe bullets, and 5 mechanisms of injury involved in blast injuries. So different mechanism of injuries. We'll describe the priorities of pre-hospital trauma related to preventable of death, and we'll talk about preventive efforts in reducing injuries or death due to trauma. So, most common cause of traumatic death, we have different reasons. The most common ones is either road traffic injuries, intentional injury, suicide, or falls. So there is a relation between time and patient survival. Anybody can tell me what is the relation between time and what is our target to stay on the scene? Can we stay more? Yes, if the situation needed us to stay more, we have to stay, but our target is to stay 10 minutes, and we call them the 10 platinum minutes. So that's our target. Now, our target also to be in the hospital within the golden hour. So anybody can tell me what is the golden hour?
So the golden hour starting from the scenario started or the scene started until we reach the hospital, including the 10 minutes in the scene, the platinum 10 minutes.
Okay, so 1 hour is actually the 1 hour started until we reach the hospital, that's correct, but it will started from the incident time. So if the accident happened at 10 a.m. and I respond to the scene at 10:30, the golden hour started from 10. And the reason why we have the 60 minutes or golden hour, because of the mechanism of the injury, the internal organs of the body will take around 1 hour, mostly the kidneys. That's why we are considering from the incident time, if we know it. Okay, in trauma, like in resuscitation, we do have a teamwork and a team leader, and that's very important to have an organized response to trauma. So we talked about scene size up, and this is the main talk here in the first lecture. The scene size up, as we know, it's the first step in the So
if the scene
let's ask Amjad. Any idea, Amjad?
No.
What could be included in scene size up?
The scene safety, number of patients, of injury, type of injury. All this we can include in the scene size up.
Okay, thanks Hassan. عبد المولى صح أنا؟ تفضل.
صباح الخير يا فراس. صح مزبوط، نفس اللي حكاهم عصام، بس ما كنت رافع ايدي عشان احكي بس.
تمام، شكرا لك. So scene size up، احنا في عندنا السيفتي، الهازارد، number of patients، mechanism of injury، والريسورسز الموجوده في الفيلد او اللي موجوده معنا. So هذه الانيشال ستيبس. Sorry.
Again, please, فراس.
السين سايز اب تحتوي على أو first of all الهازارد or safety. So what hazard on the scene. تحتوي على number of patients. تحتوي على mechanism of injury. تحتوي على resources, available resources on the scene. If you have enough or you need more resources. Okay.
Done.
هذه الستبس تبعية البرايمري سيرفري وتبعية السكندري والري اسسمنت. هذه الستبس كاملة بس we'll go through it later in the next lecture. So this is the steps of the scene size up as we mentioned. Standard percussion, scene safety, initial triage depend on the number of patients, need for more help and mechanism of injury. So scene safety. Always if we know the hazard, we should stay away from the hazard. If we don't know what is the hazard available on the scene, we should anticipate it that could be the hazard. An example for that is what happened in our recent incident in Khalidia. So you have to either to anticipate what's the hazard available or to consider asking the specialist people about the hazard. Where is the hazard? As an ambulance, when you go to the scene, you have what we call the windshield survey. That's mean from the screen, from the windshield, from the window, you can look out and you can see or you can anticipate the hazard, especially if it's a road traffic accident. So at least you can see what's going on and you can expect what could be a threat for patients or for you or for bystanders. So the mechanism of injury, we will have either generalized mechanism or focused mechanism. So anybody can tell me an example for focused mechanism?
السلام عليكم. زيد سلامة. يعني مثلا إذا كان مثلا على سبيل المثال كار رول أوفر، بتختلف معانا إذا كان مثلا كار فور هيد كولوم or something.
Okay, the focused mechanism, thank you. That could be a general mechanism because you involve different parts of the body. The focus mechanism will be involving only one part. So if there is, for example, a gunshot wound, if there is a stab wound, so that will be connected only to one part of the body. That's a focus mechanism. What's the difference? Why I'm saying focus and general? What's the importance of that? For the general mechanism, when I do my assessment, I will do head-to-toe exam and I will examine everything. When I do a focused assessment, I will do head-to-toe, but I will make more focus on the area or on the place where I have the injury. So that's the difference. So as we remember, we studied before a long time ago physics and other subjects. So if we have a high energy, we expect to have a severe injury. So if you go to a scene, motor vehicle crash, and I will tell you that the crash happened at a 200 speed you would expect a severe injury. If I will tell you the crash happened at 20 kilometer speed, you will not expect that severity of the injury. So high energy, high speed equal to high risk of injuries. So some motion mechanism could be which could cause a blunt injuries could be the rapid forward deceleration, rapid vertical deceleration, and blunt instrument injury transfer. So what will be an example for rapid forward deceleration? First of all, deceleration is a sudden decrease on speed.
الكار accident هاي بيكون عليهم.
Yeah, car accident, especially if the car, let's say, if someone driving a car and he hit a car which is completely stopped at somewhere. So then the car which is in the back will have a sudden decrease in the speed, and that's a deceleration. What about vertical deceleration?
Like fall down something.
Fall, yes, exactly. Fall from a height. That could be a vertical deceleration. Blunt instruments. Can you name any instruments which will cause blunt injuries? Sorry? Maybe wheel of the car, maybe a hockey stick, maybe like a football. So any of that could cause blunt injuries. So in the mechanism, in the motor vehicle crash, like this is an example. One day I was involved in a crash and I was in similar situation. So if you are inside the car and you hit a car, a tree, a wall, whatever. Now, as you see here, the car is damaged because it will absorb all that energy. But that energy will not be absorbed completely by the front of the car. Some of that energy will transfer toward the steering wheel. So that one will come here to the steering wheel. If you have the seat belt will protect you, will take you away from the steering wheel. If you don't have it, then your body is going to move toward the steering wheel. Once you hit the steering wheel, that energy will transfer from the steering wheel to your body. Now, it will transfer through your body to your internal organs. So that's the mechanism of any trauma or injury. So how you can tell if you are now driving your ambulance and you see this picture, how you can tell what type of injury or if there is an injury or no from that picture? By looking only to this picture.
Yes.
What do you expect?
Expect severe injury.
Can you give me some expected injuries? Like
spinal injury. Simply spinal injury, fractures, pelvis injury.
So pelvis, fracture,
head trauma.
Maybe head trauma. If you look here to
lung and ribs injuries.
Maybe if he had the steering wheel, yes.
Especially if he didn't have a seat belt.
Exactly. So that's mean if you go to the car, you are looking now to the deformity outside, you are looking to the deformity inside of that car structure, and you are looking now to the safety measure, if there is an airbag, if there is a seat belt. So all that, we call it a clue for injuries. So all what you mentioned will give you a clue what kind of injury you have to expect on this person. And so the clue of injuries, you look to the deformity of the vehicle or the interior structure, and or if there's a deformity on the patient himself. So if you have frontal impact collisions, as you mentioned earlier, you might have a windshield injury. As we see here, it's broken. So if there is no seat belt, maybe he hit that by his head. So you expect head injuries. a steering wheel injury if there is no seat belt, or sometimes even if you have a seat belt, but you are very close, so your seat is very close to the steering wheel, you still have a steering wheel injury. That's why they mention if you have an airbag, you have always put your seat back to the maximum. That means you have to drive, you have to be comfortable when you're driving, but your seat should be at the maximum limit in the back, so you will be far from the airbag. So steering wheel injuries and maybe dashboard injuries as well. If you have a lateral impact, that's mean from the side, what you will expect, what type of injury you expect on those patients?
Fractures also in the side of the back, spinal injury also.
So similar what we have in the front impact. Adding to that, you may have even focus fractures now on the side of the impact. So that will be similar to what we have. Mostly here, ribs will be involved in the lateral impact. So you expect maybe you will have ribs fractures, maybe flail chest, and maybe pneumothorax. So that's more could happen on the lateral impact. What about a rear impact? Somebody hit you from the back. What could be special with the rear impact?
Neck.
That's spinal injury, neck
Injury.
Spinal injuries. Correct. What about rollover?
Rollover head injuries.
Multiple injury, depend on what? What will be making a difference in a rollover?
How many over and
Time.
speed?
So if I hear you correctly, you said how strong it is?
How?
Okay, if there is a seat belt, if there is any restraints or no. Yeah, that's
the speed and how many times over?
How many times he roll over. Now, one thing else, what free objects we have in the car. So if for example, if somebody driving the car, he have heavy object, metal object or any solid object. So he have heavy object and he did that roll over, we expect that he will be hit by those objects, and that will cause a secondary trauma to him. If he, as you mentioned, if there is no safety or seatbelt, he might be ejected from the car. And if he's ejected from the car, then as you see, the chances of death will increase 25 times. And I have been in many scenarios where I have seen people ejected from the car. They stand, they said, we are fine, we are okay, we are good to go. And they end their day in the operation room, and most of them, they lost their lives because they bleed enough to die. So this is the big vehicle. How about small vehicles like motorbike? Now we have a lot of motorbike everywhere in the city, from Talabat and from other companies like that. So delivery, and I guess you start to see more injuries, or if you are in a place where you don't have those motorbike, maybe you heard your colleague or your friends mention that they will have now more injuries from the delivery people. So what kind of injury you expect from those people or those injuries?
Head injury, spinal injury, fractures, pelvis fractures everywhere.
Again, head, pelvis fractures, especially that those small vehicles have no protection like the car. So in the car, you have protection from all the way around you. With this small vehicle, there is no protection, so that the driver can have a direct impact on his structure or his parts. So you can have more injuries now on the spinal or as a fractures. So the occiput restraints, we have 3-point restraints. This is the similar what we have in the car if you are a driver or a passenger. And we do have the lap belt, and that's mainly if you are sitting in the middle seat. So different restraints also can cause some injury. So as we mentioned, if you are close, like very close to the airbag, you might have injury like fractures in either in your clavicle or in your ribs as well. If you have the abdominal belt or the lap belt, you can have head injury or also abdominal injury as well. So safety is good, but it might also cause some injury depending on the speed and the mechanism of injury as well. Now, the airbags is a great invention in cars, but it also could cause some trauma, especially as you mentioned, if you are very close to the airbag itself or the steering wheel. So there is a powder inside and chemicals, and that will cause the inflation once we have an impact. It's also it will be sometimes not deployed. So when you enter the car in the trauma assessment, you have to take care of that. If that car is a car provided with an airbag, you should be carefully working with the patient, making sure that the airbag is not going to open in your face. As you mentioned earlier, the vertical deceleration fall is one of the examples of that. The severity of the fall, as you know, it will depend on the distance of fall and which part of your body hit the area and the structure. Are you on the sand or on the asphalt, or what is the structure? And also the patient age. So an elderly person, 80 years old, fell from 1 meter can cause or can have a severe trauma, while an adult could survive that with no injuries. So also the age. Penetration trauma, it will depend, the severity of trauma will depend on the object itself, the length of the object, the angle of the object, and the type of the object, if it's what kind of knives we use, and also the length of that blade. Trauma related to gunshot wounds will be depend on the speed of that bullets and the caliber. How big is that bullets? So the speed, the caliber, and also the distance between the object and the body. In the blast injuries, we do have different mechanism now. We do have 4 mechanisms. So the primary mechanism will happen when the explosion happen and that person fly away. The secondary mechanism will happen when any object comes here following that person or that patient. The third mechanism could happen when that person is ejected or hit some area or somebody, or maybe like a tree, wall, whatever. A fourth mechanism could happen from chemical or fire or burns from the explosion itself. And the last mechanism could happen also from any chemicals or nuclear available in that explosion. So that's a mechanism we could have in a blast injuries. So the priority of trauma, as we know, we do follow the ABCs, but in trauma, if there is any bleeding, we take care of the bleeding first. So bleeding, hemorrhage, we can see. So massive bleeding first, and then I will go through the ABCs. So if I will do a trauma triage, and I will see that I need to transport patients to a hospital, which need to manage trauma patients. First of all, I'm going to look to the vitals and level of consciousness. So if I have a good vitals, I'm going to continue and assess my injury. If I don't have a good vital, so I have decrease in systolic blood pressure, decrease in high increase or decrease in respiratory rate, I don't have a good Glasgow Coma scale. At this moment, I'm going to consider that patient to go to the trauma center. And if all these vitals is within the values, then I will go to do my assessment, and I will check for any fractures. If there's any pelvic fractures, any paralysis with this patient, any long bone fractures, any chest wall instability or deformity. So all these injuries will take the patient again also to the trauma center. If none of these injuries happen, then I will continue and I will assess the mechanism. If the mechanism is one of those, so it's for an adult is more than 20 feet high, for children is more than 10 feet high. So 3 feet equal to 1 meter. You do the calculation. And if there is a high risk, like you have, like you are in you respond to a person who is in the car and somebody else beside him in the car, he did because of the injury. So you expect the mechanism of injury should be really high. Motorcycle crash with over 20 kilometer speed, and that will consider high mechanism, taking the patient to the trauma center. If not, then you will continue your assessment and you will check extra consideration. So you look if there is any, if you have a burn patient, where is the burn? If it's in certain areas, like face, head, that should be taken to a trauma center. If it's a pregnancy involving trauma and the pregnancy is over 20 weeks, that will go to a trauma center. If there is systolic blood pressure is more than 90, like 100, 110, but the person is an elderly person, so you expect that also need to go to a trauma center. So different mechanism, you look for those mechanism, and based on that, you will decide to take the patients to a trauma center or no. And when we say trauma center, specialized hospital to treat trauma. Right now in Abu Dhabi, we do have Sheikh Bout as the main trauma center. So in summary, trauma is a disease of time and energy. When you organize and have a teamwork, that will improve the outcomes in a trauma assessment and management. Scene safety, scene size up will come first always, and knowing your mechanism of injury will help you to predict the injuries and to treat the patient better. Any questions? Okay. So right now we'll go to the other main topic we have, which is the trauma assessment. I'll try to open that. Let me check first of all how many person. Nobody extra came. So that's we are only 7. Okay. That's a light course actually. Okay, so trauma assessment and management. On this talk, we'll talk about the steps of the trauma assessment. We'll describe the primary survey, secondary survey, and the reassessment of trauma. And also, we'll talk about different critical conditions, life-threatening injuries in trauma, different intervention that should be made during primary survey. And we'll discuss, as you mentioned, the secondary and reassessment. So the patient assessment, as we talked earlier, will have a primary survey. Scene size up is the first part, as we mentioned. And then we have initial assessment, rapid trauma survey. That's all, that three components included in the primary survey. After that, we'll go to the reassessment, secondary or secondary reassessment based on time. So in the primary survey, after we finished the scene size up, we started the initial assessment. You look to the general impression of the patients. As you mentioned, you look to the hemorrhage. If there is an excessive hemorrhage, and then after that, you look to the ABCs. Then after that, we'll start with them, look to the mechanism of injury, if it's localized or general. If it's localized, we'll do a focused exam, and if it's general, we'll do a rapid trauma survey, and then we'll decide this patient is critical, non-critical. We'll do transportation, depend on the time. If we have very short time to reach the hospital, we'll do a reassessment exam, and if we have enough time, long time, we can do secondary, and then we'll do the reassessment after that. So this is now focusing on the primary survey only. So as we mentioned, this is the scene size up, initial assessment, looking to your general impression, looking to a hemorrhage, if there is any, level of consciousness, chief complaint, and then the ABCs of the patients. As we talked earlier in the first lecture, this is a teamwork. So if you have a team, you need to delegate intervention to team members. So if you are more than 2-3 persons on the scene, one of you should be a team leader and should delegate the job. So what that's mean? That's mean I can do, when you talk about ABCs, I can do ABCs at the same time. So someone will do circulation, someone will do breathing, someone will do the airway. If I'm the only one, then I will go through the process. But if there are more than one, then we can delegate and do more than one at the same time. We will not stop the assessment for the patient. As we mentioned, we have the platinum 10 minutes. We need to finish as soon as possible. And I will not stop my assessment unless I have any unsafe environment happening now, or there is an action needed. For example, I'm doing my assessment. We have an airway obstruction or cardiac arrest happened. I need to deal with that. So the primary survey, repeating again, scene size up will include standard percussions, hazard number of patients, need of additional resources, and mechanism of injury. Anybody can give me an example of hazard on any scene, either medical or trauma call, or sorry, trauma, we talk about trauma. So either in home or outside home.
Typical hazard.
Gas, electricity, yeah.
Any chemical in some accident.
Chemical, yep.
Oil, gas leak from the car.
Oil, gas leak.
Maybe fire.
Can people be a hazard for you?
Yes.
Yes. Too many people or too angry people as well. Could be also a hazard for you.
And the
We
location
can't- we
also,
can't deal
location of the
with them.
patient.
Sorry?
The location of patient.
Location of the patient as well, maybe, yeah. Or the place itself, if it's a confined place. Yes, you need the special equipment for that. So in initial assessment, we start, as you mentioned, with the general impression. So you look to the patient when you are moving toward your patient, or even when you are in the car, if you see the patient on the street, if it's a motor vehicle crash. You look very quick to your patient, and you can tell approximately the age, the weight, the sex, the general appearance of the patient, how it's look like, how is he sitting, is he prone, is he supine, is he moving or not moving at all? Is there any injury you can recognize, you can see from far away? What is skin color right now, based on what you see? So all that you can see from when you are walking toward the patient. And also you can look for any life-threatening bleedings if you can see it, external bleeding I'm talking about. So if you can see an external bleedings, or you can see signs for external bleeding, like for example, a cloth is full of blood, soaked with blood, or there's a blood under the patient, so you can tell there is a bleeding somewhere, you need to check for that. And after that, look for the level of consciousness of that patient, and using the APO, so alert, verbal, pain, and responsive. You can look to the chief complaint or chief symptoms or the main injury. If there is a motor vehicle crash, basically, you know what kind of trauma involved. If it's a fall at home, you can ask your questions to recognize where is the main injury or the chief injury. And then you go to your ABCs. So when we do our initial assessment and you reach the airway, C-spine should be controlled by that time. And you look to the patient. Is there any snoring, gargling, stridor, silent? So if there's a snoring, what's your action?
Open the airway. Make sure it's clear also.
Open the airway, make sure the airway is clear. Great. If it's gargling sounds.
Suction.
So that's what you do. There's a fluids, could be blood, could be any type of fluid. So you need to do suctioning for that. So what if you have stridor? What that will tell you. So also there is an air obstruction. Silence. If there's no air entry.
No patent.
So if there's no air entry, that's mean maybe you will have, for example, tension pneumothorax, and there is no air entry, silence. So after airway, you go to the next step. You go to the breathing. On the breathing, you will check for, first of all, is there breathing or no? That's number one questions. Then if there is breathing, what's the rate, depth, and efforts? I don't need to auscultate right now. I don't need to listen. Remember, this is only initial assessment. When it comes to the rapid trauma survey, that's the time when I will do a further investigation for the ABCs. Right now, I just wanted to know he's breathing or not. If he's breathing, what's the effort and depth and rate of his breathing? Then I will go to the circulation. In circulation, again, my main target is to know, first of all, I will check the radial pulse. Is there any radial pulse or no? If I have radial pulse, great. If I don't have radial pulse, I will go and check the carotid pulse. Then I will check the quality, rate, rhythm for that pulse. After the pulse in circulation, three main things I need to check. The heart, the skin, and bleeding. So the heart, you check the pulse. The skin, you check the color, temperature, moisture, and also capillary refill. And on bleeding, you check any external bleeding you can see and you can control. So why I will go to the radial first? What information the radial pulse will give me? So what's the anticipated blood pressure if I have a radial pulse?
Above 90.
Yeah, it will be 80 to 90. So which is enough to do a good circulation, enough circulation to the different parts. So 80 to 90 if I have radial pulse. If I don't have radial, I have carotid pulse. What that will tell you? So low systolic pressure expected, maybe around 60 to 70. If you have, if you have, sorry? Yeah, you might have patient who's developing hypovolemic shock in that situation. But at least you know there is a systolic pressure at this moment, so it's not completely arrested. If you have a femoral pulse, that will tell you are in between the radial and the carotid. So if you have a femoral, that could be 70 to 80 systolic pressure. So now we have done the ABCs. Initial assessment is done. We need to go next to the trauma assessment. After we finish the initial assessment, we need to think about the patient. Is this patient having a critical or life-threatening patients or no? That decision will give us the idea on the situation and if we need to initiate a quick transportation to the hospital. So maybe I will guide my partner to go and grab the stretcher and all the other equipments needed for transportation if it's not ready yet, and I will continue the rapid trauma assessment. So rapid trauma survey target, our target is to take around 2 minutes. That's the target. 10 minutes is the maximum. 5 minutes or less, that will be great if we can achieve, especially for critical patients. And remember that we don't do any procedures on the scene except, and that's for critical patient now we are talking. If it's a stable patient, you have time. But if it's a critical patient, there is no time to do any procedures except if it's life-threatening or life-saving procedures. An example for this, if you have a forearm fracture, it's not a life-saving procedure right now if it's just a fracture. But if I have severe bleeding, if I have internal bleeding with pressure deterioration and consciousness deterioration, that's life-threatening, that's critical. I need to transport him as soon as I can. If I have to do any intervention, I should continue my survey and ask my partner to do. So ask as much partner as you have, ask him to do any action. Once I start my survey, I should not stop unless, again, we have bleeding, severe bleeding, life-threatening bleedings, or cardiac arrest, airway obstruction, or danger and safe scene. So that's the only time I will stop my survey. Other than this, I will continue my survey and transport the patients to the hospital. They repeated again here for the general impression. I can look quickly to the patient and see if there is any severe bleeding I can see. That's when I'm walking to him. I can give an approximate age, 6, weight. I can give a general appearance, the position of the patient, and the activity of the patient. Now, if I have more than one patient, this is the time where I need to do a triage to the patient. So when we do triage, after we look to all that very quick, when I arrive the patients, I will do triage. So I will do a quick ABCs and decide where this patient will go. We mentioned earlier level of consciousness will be done based on the AVBO, and AVBO is the AVPU, alert, response to verbal, response to pain, and unresponsive. We mentioned again in the primary survey, you look, listen, and feel to the airway, and maybe you need to change the position or suction on the airway. For breathing, again, also look, listen, and feel, and maybe you will give a high flow oxygen. So one of the action needed here is the oxygen. So if there is a need for oxygen, you will give it here after you check the ABCs, after breathing. So oxygen will be given here. This is one of the critical action you need to apply in trauma, especially now in your practical test, you need to focus on this. So oxygen will be given after the breathing in the initial assessment. Sequeler will be given to the patient after he finished the neck assessment in the rapid TOTO exam. So this is two critical action you need to know when you will do them. Some of the normal values for respiratory rate. So for your records. So in the primary survey, as you mentioned, we talk about A and B. They repeated here the C. So you're looking for peripheral pulse, the quality, you will interrupt only if there's a cardiac arrest, and you look to the skin color, temperature, and condition. Mechanism of injury decision. If it's if it's a general mechanism of injury, I will do the rapid trauma assessment or survey. If it's a focused injury, as we mentioned earlier, it will be a focused exam. And that's the rapid trauma survey. So the rapid trauma survey is a trauma assessment will be done from head to toe, starting from the head. So I will look to the head first if there's any cut, bleedings, bruises, fractures. So you look to the head and then go to the neck veins, to the neck itself actually, see if there's any pain, any bleedings, any tick, tenderness, instability, and crepitus. So if there's any movement in the bony part, if there's any pain while you touch, and you look to the vein, if it's distended or flat, you look to the, if there's any tracheal deviation or no, or trachea in the midline. Then after that, I will go to the chest. When I come to the chest, I'll check the clavicle, check the ribs. So checking the chest, I have to go through organized process. So first of all, I should do inspection by looking. So I will look. I need to expose the chest. I need to look with my eyes. And after that, I will do palpation. So I will with my gloved hands, I'm going to palpate. And palpation will give me an idea if there is any fractures or flail chest. So, and also I'll check for any tenderness, instability at the same time, crepitation. Here is the point or the time to check for breath sounds. Now I'll do auscultation. And when I will auscultate, I will make sure I will compare the right and left. So I'll check right or left and compare, see if, first of all, the breath sound is present, and then after that, if it's present, is it equal or no? I may check for heart tones if I have experience with that. And after that, I will go to the abdomen. Again, in the abdomen, I will divide the abdomen of the patient to a 4 quadrant, and I will check and compare each quadrant by itself. So I will hit the left or right, upper or lower quadrant and move to the next ones. And I'm checking here for any tenderness, if there's any contusions, any rigidity, soft, distension, penetration. So I'm checking all that in the abdomen. After that, I will go to the pelvis. On the pelvis, I will check again for the tick, tenderness, instability, crepitus. Is the pelvis moving? If it's moving, this is the time to keep it stable and have maybe a strap, and no need to check the pelvis after that until we reach the hospital. Then I'll do the lower upper extremity the same way. I will check for tenderness, instability, curvatus, looking for any swelling, fractures, deformity, bleedings, and we'll do also the upper part as well. During the lower and upper part extremity, I'm going to check for the motor and sensation. So I'll ask the patient to move his finger, his toes, and I can touch one of the finger, one of the toes, and ask him which one I'm touching. So making sure that he have enough sensory feelings. At the end, posterior, if I have a chance to do it, I will do it. If not, maybe when I move the patients on a scoop, on a board, or transfer him from the location, I will check for any obvious deformity if I don't have to check that earlier. If the patient critical, we'll transfer to the ambulance and complete the rest of the exam. So we'll do vitals, we'll check the pupil size, Glasgow Coma scale. If the patient is not critical and there is enough time, or I can take some more time on the scene, I can do that before we go to the ambulance. And those are the steps we talked about. And as you mentioned, if we have a critical situation, we'll transfer to the ambulance to complete the assessment. So the completion of the assessment, again, vital signs, Glasgow Coma scale, and if there's any alert tag or medical jewelries, maybe this is the time I will look. So I will consider other causes. So that's for your records, Glasgow Coma scale. And when I will take the Glasgow Coma scale, I will go always to the best response. So if I'm confused between he responds to voice or pain, I will go to the best response. So priority patients, if I have a high-risk group like elderly, children, pregnant lady, if I have a high mechanism of injury, if I have decrease in the level of consciousness, that's a critical mechanism of injury, need to get transported. When I take the vitals and the Glasgow Coma scale, I might also take the sample history. So the sample history stands for symptoms, allergies, medication, past medical history, last oral intake, and even preceding the incidents. Some of the load and go situation, if I'm doing my initial assessment and I have decreased level of consciousness, issues with respiration and circulation, that's a load and go situation. If I have pelvic instability, femur fractures, like bilateral femur fracture, I expect to have a severe bleeding, internal bleeding. So then this is a load and go situation. So any significant trauma or mechanism of injury with a poor presentation to the patients, that's a load and go. I need to go directly to the hospital. Some critical intervention I need to do for patients on scene. And if you look here, you see we do have maybe open chest wound. So they put the valve. So he have the gloved hand over the open wound, and then he covered that with the seal, with the German seal. So if you don't have a life-threatening, like as you mentioned, a small fractures, like bandaging, then I don't have to do that procedures on the scene. If it's a life-saving, stopping the bleeding, open chest wound, then I can do that on the scene. Now, a reassessment. A reassessment, when I will do reassessment for trauma patients?
I'm going to the hospital.
So in the way to the hospital, yes, I will check my intervention. Yes, I will do that. What else? What I will check else on the reassessment exam?
Any changes in vital signs, for example?
Perfect. So any changes, I'll check the vitals and make sure there's no changes. Okay, good. So intervention, vitals.
Focus in department of body that will be hurt.
Good. So you focus if there is any localized or focused exam you have done or injury, you need to recheck that. Okay. Okay, that will be actually a secondary. So to expose more and to know more which you didn't recognize, that will be in secondary. On the reassessment, from its name, remember it's reassessment, you want to check any changeable vitals or appearance on the patients. And that's include the ABCs, that's include the vitals, that's will include the level of consciousness. So that's all, and that's include my intervention. All those could be changed. That's why I need to reassess them on the way to the hospital. Or if I cannot transfer the patient to the hospital for any reason right now, I will do that also on the scene if needed. So how often I will do the reassessment? Okay, so stable 10 to 15 minutes. In Itls, they say 15, but if you have time, yeah, fine, you can do it 10 to 15 minutes. Critical every 5 minutes. Every 5 minutes, this is the maximum limit. But if you have time, like let's say, if somebody decided to check all that every 2 minutes, that's okay. You can check every 2 minutes. You can check every 1 minute. You can check every 3 minutes. Depend on your time, but no more than 5 minutes. So you can check that. Great. And this is what you mentioned earlier. So secondary survey. So this is the reassessment. How about the secondary survey? What I will reassess on a secondary survey?
ABC.
So ABC, yes. And detailed exam. So detailed exam, that's mean I'll check everything. So I will repeat everything from head to toe with more details. Maybe in the rapid trauma survey, I saw a small finger fractures, minor bleeding, and I didn't consider that in the rapid trauma survey. In the detail, that's the time I will consider all those injury. And I will do more detailed exam. So if you remember in the rapid trauma survey, I used tenderness, instability, and crevitus. That's a very quick assessment. On the secondary survey, I'm going to use the different exam. So I can use the, I just forget the word. So you do a detailed exam to that to that person, and we use the DCAP BTLS. So DCAP BTLS stand for different words. Anybody can tell me what stand for?
Penetration, restoration.
Yeah, swelling. Exactly. So here we do more detailed exams. So we do the DCAP BTLS on those patients. So the secondary is a more comprehensive exam. and will evaluate the whole person and the whole injuries. So the critical person or patients will do that on the way to the hospital if we have time to do it. If it's a non-critical, stable patient, especially if we cannot transport this patient for any reason, then I might do it on the scene because I have time. So in the secondary, as you mentioned, I will repeat the initial assessment, I will repeat the vitals, and then I will do the head-to-toe decab BTLS exam. And I can also repeat the tenderness and stability crevices. So that could be done again. Some of the normal vital values also for your info. Some of the adjuncts I can use for patient assessment. This is some of the equipments like the pulse oximetry. I can use the capnography. Some of the devices could check the serum level, so I can predict shock for that. And all those equipments used in hospitals, some of them used in ambulance services and our services. And also we have the portable ultrasound, which is the FAST, and that will help us to recognize bleedings and trauma. And it's used by ground and air ambulance, especially for long distances. That will help us to recognize cardiac tamponade, hemorrhage, and pneumothorax. So for long distances, that's a great tool to have. When you're transferring care, when you're transferring patients or hand over the patients, most of the hospital have the MIST report, or they would like to receive the MIST report. And the MIST report, I guess you used it as well in the ambulance. So the MIST reports will help the receiving facility to know what is the mechanism, what's the medical condition or complaint, and what's the injury to this patient, his vitals, and what treatment you have done up to the moment he reached the hospital. So basically, that will give a summary of all what you have done. So any questions we have before we move on?
No questions.
So in summary, we talk about, we'll repeat again, the patient assessment. It's a very important piece of the trauma care. Time critical. We have different type of assessment. We need to do them in order. Do it as fast as I can. Organize and use my team delegation when it's needed. Remember, patient assessment, tomorrow we will have two stations. We'll have a station for patient assessment 1 and patient assessment 2, which is the main station for the course. When we do a practice for practical test, we'll do also patient assessment scenario with treatment. And then in the practical assessment, we will repeat also and do scenario where we need to use the patient assessment and treatment plans. So treatment assessment is very important. Today, I'm going to share with you an important document so you can review it. And tomorrow, I'm going to give it to you printed as well. Thank you all. You can have 5 minutes, but don't stay away. So you can have 5 minutes until we arrange for the next talk. Thank you all.
10 minutes.
Sorry?
10 minutes, please.
10 minutes. Okay. Let's take 10 minutes. So now it's 9:50 on my time. So at 10 a.m. on my time. So 10 minutes from now you counted, and then we will start.
Thank you.
Please stay with us the whole day. So I'm taking your attendance during the whole time. Thank you.
A medical patient and a trauma patient during working with the airway.
It's different jaw thrust and head tilt chin lift.
Yeah, the jaw thrust and head tilt chin lift. It means the main thing is to stabilize the cervical spine. If we do have any medical patient, we will not ask anybody to maintain the C-spine. But during all the trauma patients, you do have any patient, whatever the situation. If it is a traumatic situation, you will start by dealing with the C-spine stabilization. This is what is opposing the medical scenarios with the trauma scenarios. All the time, you have to ask anybody else to just stabilize the C-spine. Very good. Then we will start working with the airway management, and we will go to see the objective concerning this. Just let me just work with it a little bit. Okay. The objective will review the anatomy of the airway, of course, and we will see physiologically and for the respiratory system. We'll explain, of course, the importance of the airway control. I think everybody will know what we'll talk about. The supplemental oxygen. We will just describe a little bit indication and contraindication concerning all these adjuncts we have to work with. I think we do have all of them inside your ambulance. And we will see if there is any difficulty, what are the notes that we can take if we will do an endotracheal intubation, and we will describe a little bit the essential components of an airway kit. I think you do have it all also inside the ambulance if you are working inside the ambulance. Then, for the airway management, as we are talking about, is first of all to open the airway, okay? We want to open the airway and we'll support oxygenation. How can we support oxygenation? By giving oxygen to the patient who is in need, okay? Then we will see which adjunct we can use in this situation and how can we give this oxygen to the patient. Of course, we will have adjuncts and we will talk about the situation which is critical to give oxygen to the patient, and we will see how we can do with this kind of patient. Then, sometimes it will be difficult for us to maintain patent airway. I know the one working in the field, the environment is all the time unpredictable, right? Sometimes you have to provide airway in different situations. Sometimes it is on a shopping center, sometimes it is on a highway, sometimes it is on the side of a road. It is not very easy. And of course, in our environment, everybody will be a responder and he will be a paramedic and he will let you know to go fast and quick and to give, to treat the patient. All the time we know we are dealing with this kind of persons. Then sometimes it is very difficult to maintain a patent airway. As they said, for example, the light is not good. The location, as we said, it might be in a highway. It is not safe for you. Or in a shopping center, a lot of people are there surrounding you. Or there is a bleeding, or there is a facial disrupted anatomy. It will be very difficult for us to maintain a patent airway. Then the first thing all the time we are looking about it is hypoxia. How can we just deal with hypoxia? What do you think? To avoid hypoxia, what we have to do? Islam or Isam?
we can maintain the airway open, and we can get oxygen also.
Yes, we try to maintain the airway open and patent, and we try to stabilize the airway on this situation. And of course, we will try to give oxygen to the patient. This is our goal. This is our aim, okay? This is why when you have a person who is in respiratory distress, then you have to think that he might be hypoxemic. And if he's hypoxemic, it means he will be having a problem with the brain and a problem with the organs. And then we have to see what will be the reason of this. What might be the reason? It might be an upper airway obstruction. It might be due to hypoventilation. If we do have an upper airway obstruction, what we have to do? We try? Tell me. How can we anticipate?
The sounds of breathing, sounds of air entering, like...
Yeah. If you do have an upper airway obstruction, we will see. We try to readjust the head, okay? What we are using? We are using, for example, as you said previously, the jaw thrust maneuver, okay? To try to open the airway. If we are just having an hypoventilation, we will assist the patient in getting the oxygenation needed, okay? If you have a pneumothorax, we will see how we can check the pneumothorax and if we can do something on the field. This is our job here. We try to get the diagnosis, and we try to get it. How can we do this? How can we deal with it? This is why, for example, if there is any airway compromise, and for all our patients here, if you do have EMT basic, we ask them to call for the backup. The backup will be helping you by medication, by adjuncts, and by advanced airway. Okay, this is the reason we let you all the time tell the backup to come. Then we are talking about the initial airway management. If we are talking about airway management, we say this is very important trauma care task. Of course, before opening the airway and without getting an open airway, the patient is not able to breathe. He will not be able to get a good circulation. This is why we start all the time by the airway, okay? As we said, we are talking about challenging in the field. How can we be a challenge? Because we were talking about highway, people, a lot of things to do with how can we deal with the patient. And it is time critical. You were talking previously about the golden hour. This is a very time critical. Why? The golden hour, if you cannot open the airway, if you cannot keep it patent and give oxygen to the patient, it is a critical situation, and it will be a long-go situation. This is one of the three things. We are talking about alterated mental status, breathing problem, and circulating problem. This will be a long-go situation. It is unpredictable because we didn't know what will happen. And of course, need options and alternatives. We are talking about basic adjuncts, and sometimes it will be an advanced adjuncts, okay? Then, even for our EMT paramedic or for the doctors, we always start with the basic. The basic will be the maneuver, OPA, NPA, and we try to work with. Then we'll see if we are in need to go to the advanced adjuncts for the patient. Then we will review some anatomy and physiology. Of course, if we are talking about the airway, there is what we call it, it will start from the nose and the mouth. Of course, we go to the nasopharynx, then oropharynx, then hypopharynx, where there is a when we are trying to go to the advanced adjuncts, you have to know the exact anatomy. You have to go to do the centimeters. Like this, you will do a right intubation for your patient, okay? We know that the nasal cavity and the oropharynx, they are lined, we have delicate, they are highly vascular. Then if you will introduce, for example, an NPA, we know that we need to lubricate, okay? Then we know also that the nasal cavity is divided, and there is a very vascular midline septum. This turbinates that can get in a way when you are inserting tubes. Then you have to recognize if there is any turbinates. The nasal adjuncts, if you will introduce any nasal adjuncts, they have to go straight back, okay? You no need to go up. You have to go back because you know that the brain will be almost, if there is any basilar fracture, you have to be careful. We will see this during when we are doing the workshop. But if you are introducing anything through the nose, try to get to go straight back, okay? And if you are talking about the oropharynx, sometimes we have to see the teeth and the tongue because sometimes the tongue will be the one obstructing the airway. Then this is why we are asking to do this, the jaw thrust, to just keep the tongue up and it will be opening the airway, okay? When you are doing this lifting the jaw, it will be opening the airway by lifting at the same time the tongue and the epiglottis. And you know that the tongue is, when the patient is unconscious, it will be the mostly muscle and it will be doing the potential obstruction of the opening. Now, just to have an idea, you see when the airway is already obstructed here, you can see that once you are just lifting the jaw, what will be happening? You are just taking with you the tongue and the epiglottis anticipating about the injuries that you can face. And once you reach the patient, you will assess him, and you will see how is he breathing and how is the airway. Is there any sound, of course. And then, of course, before starting working with the patient, you have to do a training. The aim of this is to be able to treat the patient or to do whatever you need for the patient, and you have already hands-on. The scope of practice also will be very useful for you, because I know that there is some guidelines you have to use and you have to follow. For example, there is, we do have, if I am talking about the ambulance that we are working on, we have different EMTs, basic, intermediate, and paramedic. And all of them, they have their own scope of practice. If you see that this is beyond your scope of practice, then call for backup. This is what all the time I am saying. And all the time you have to try to be, work basically, and then, okay, Abdel Moula, I just, now I saw the message, and because I admitted twice, Karim, sorry, Karim, it was a delay. But because I saw that I admitted you from beginning, then I did not notice it. Thank you, Abdel Moula. Now it's okay, Karim, you are with us? هذاك علاش دخلته مرتين أنا عشان كده بعدين ما والحين موجود كريم ولا لا؟ مرحبا يا كريم مرحبا. Okay. عايش خوي. Then we were just talking about the procedure. How can we proceed with any patient? As I told you, you have to follow the mechanism of injury to suspect the cases. Then the chief complaint of the patient. Then you will reach the patient. You will just your assessment. Then the clinical presentation of it. What did you find? Okay. Then of course, do you have the skill to do anything else for my patient? I do not have it. My practice, do not admit me. Be careful to the timing, because what we said, we try to be keep less time on the scene. If it is a critical situation, try to load and go and transport your patient. Okay, and of course we said that we start basically. Even if you are a paramedic or a doctor, start basically. The basic will be the maneuver, and then the basic adjuncts, and then, of course, rapid transport may be the better option. This is what we are talking about. The definitive airway, of course. Now our patient is in a critical situation, and you try to maintain the airway pattern, but the optimal one or the gold standard will be, of course, the endotracheal tube, because it is 100% sure that the patient will get 100% oxygenation, okay? I know this is what they said. It is not always optimal in the pre-hospital care, because of the time, because of the field, because of the light, because of the skill. Then this is why we got other options, which are the LMA or the IGEL. Okay, like this, it will be helping you. And of course, doing this must be with spinal muscle restriction. It will be difficult to reduce the endotracheal tube. Okay, this is why then it will be increasing the difficulty with a trauma patient. This is why we are all the time telling you, call the backup or put on another adjunct, which is easier for you and will be helping the patient also. Use of medication to improve intubation success, of course. If the patient is agitated, if he's not on a complete loss of consciousness, then of course you need to do a rapid sequence intubation, you need to sedate the patient. But this will be kept for the paramedic, for the doctors, the one who's having medications. You have to sedate the patient and to facilitate the introduction of the endotracheal tube, okay? All the time, if you are thinking basically BVM, ventilation, and immediate transport following completion of the assessment will be the first option for us, okay? Because if you are trying just to get an AT tube or endotracheal tube going inside the patient, maybe we are wasting time. And what we said, Do not try to do a lot of things on the scene, okay? We do our rapid trauma survey. This will be including initial assessment and rapid trauma survey less than 2 minutes. Then we transport our patient, okay? And of course, have backup plan before initiating. It means all the time call for backup to be on the safe way with your patient, okay? If there is any difficult airway, we have this mnemonic, which is, we call it Leon, just to let us identify if it will be difficult or no. Look externally. We are looking externally for what, do you think? L for look externally. We are looking for what? Guys. نعم.
Any foreign body.
Any foreign body? Obstruction. معناتها if you are looking externally, you are looking to the patient face, right? You will see if there is any facial structure or, for example, is any trauma on the face, you cannot introduce it, or if the patient is having an obese neck. This is what we call, you have to look to the patient face and neck to be sure there is no obstacles. Evaluate the 3-3-2. What does it mean, 3-3-2 rule? You see on the picture here, this is the 3, it means mouth opening. We will count mouth opening 3, and the distance from hyoid bone to the mandible will be 3, okay? And of course, the distance from the hyoid bone to the thyroid cartilage will be 2. This is, we have to evaluate. If it is 3-3-2, it means it is okay. If it is less, it is difficult for the patient to open his mouth, or there is less distance between the hyoid bone and the mandible, it will be difficult for you also to introduce the tube. Of course, you will look for any obstruction, as you said, foreign body, blood.
The last two, what mean?
The last two, it is the distance from the hyoid bone to the thyroid cartilage. You know, it's just in شفت تفاحة آدم قبل تفاحة آدم، هكا الديستانس أنت تشوف المساحة هي 2. معناتها استعمل الأصابع، 3 أصابع على الفم، 3 أصابع تحت التشين، وإصبعين من تحت من الهيويد بون لغاية الثيرويد كارتيلاج.
Done.
Okay, Amjad?
Done.
Okay. It will be for the obstruction and the neck mobility compromise. neck mobility لأنه ليش فما neck mobility compromise؟ لأنه نحن دائما we do have this spinal motion restriction. We are just maintaining the head, and this will be it will be difficult for us to introduce the adjuncts. This is just to predict difficult airway. Okay. Then, of course, if you can't intubate, it means you can't ventilate. But usually there is this, if you can't intubate, there is an indication for surgical airway, which is cricotherotomy, if it is permitted. And of course, these are not permitted in our situation. And this technique, it is not easy to do. You need to do training and the training to be sure that you will be able to do this kind of surgery. But for us, we ask you to do basic, think basically, and work basically. Use BVM, try to put advanced adjunct, which is LMA or RJ, and transport your patient. The other adjuncts, we have to monitor the patient, of course, pulse oximetry to monitor oxygenation. The pulse oximeter will give you the oxygen saturation. Our aim will be, for the SpO2, we want it to be more than
94%
or 95%, good. And the capnography to monitor ventilation, capnography, which we call the ETCOT. نعم.
35.
Yes, between 35 to 40, right? The CO2, we are calculating the CO2 in the expired air, just to have an idea concerning the ventilation. The goal is to maintain the ETCO2 of 35 millimeter of mercury. Good. That's just a supplemental oxygen. These are some devices you can use, and the amount of oxygenation you can get. Of course, for us, the beneficial one will be the non-rebreather mask. Mask. It will be given almost 90 to 100% with 12 to 15 liter per minute for the fluid. The BVM will give also, if you are using the BVM with reservoir bag, it will be 100% oxygenation for the patient. The tidal volume, it's our N will be between, if you do our calculation, 500 by 12, it will be 6 liters per minute. This is the minute volume we need for if we need to give oxygenation to our patient. The normal ventilation, of course, this is what the air we're talking about. Carbon dioxide in blood will be PCO2 between 35 to 40. And of course, the and tidal volume CO2, it will be related directly to it. This is what, if we can just deal with the ventilation of oxygenation and we need it, it will be, and CO2 in expired air between 35 to 40 millimeter of mercury. If we do have an hypoventilation, the PCO2 will be above 40. Hyperventilation, it will be below 35. And usually, this is why we are asking our paramedics just to, when you are ventilating any patient, try to keep in your mind just the calculation. 1,000, 2,000, 3,000. Like this, you will not hyperventilate the patient. This is why all the time, I know when you are on the field, you forget this, but try to keep in your mind to not hyperventilate the patient. It will not be beneficial for the patient. This is why try to calculate it in your mind and give oxygen with using the BVM. Then if we are using the BVM, this is what we are talking about. Avoid overpressurization, okay, and avoid giving too much volume. This is what we are talking about. Use the pulse oximetry and tidal CO2, it will be helping you, okay? If you are just hyperventilating the patient, it will be less, the PCO2 will be less than 35, then no, go slowly with the BVM. The normal oxygenation, as the aim will be 100% for the PaO2, and our goal, as we are talking about, it will be for the SpO2 more than 95%. All our patients, I think you are just monitoring them with the SpO2, just to have an idea, and you can just stabilize your patient using this. For the compliance, of course, it will be when you are just looking to the patient and you are looking to the chest expansion, okay? Then you give oxygenation and you look to the chest. All the time, if we are just doing something else, you have to have an idea why you are doing this, okay? Then it will be revealing if there is any problem. For example, if you cannot be able to expand, if there is any resistance while you are giving the BVM, then it means there is an obstruction and there is some problem. And try to just rule out this kind of problems. The ventilation techniques, I know we have mouth-to-mouth, or mouth-to-mouth, it is forbidden to do it for the moment. Mouth-to-mouth, and of course, the BVM mask device. If we do have a difficulty of ventilation using the BVM, as we did for Leon for the endotracheal tube, we have the same mnemonic for the BVM, what we call it, the boots. The first B for the beards, if the patient is having a beard. And I think now it's everybody is just keeping the beards on. Oh, for the obesity, it will be difficult also. Older patients, toothlessness, and if there is any snores or stridor, it means no more BVM, and we try to go to the advanced adjuncts. The ventilation, of course, we'll talk about it when we are doing our skill station. And in a summary, we know that it is essential that when the airway is clear and patent and open and maintainable also, and you know that there is different techniques. The equipment must be all the time present and all the time. They said when in doubt, give oxygen. we are saying for the trauma patient, it is necessary to give oxygen to the patients. Do you have any questions, guys?
No, thank you, Doctor.
Thank you. I think, alhamdulillah, I think 10 minutes from Zahir now. It will be, you will have Zahir al-Daqaq, he will do for you the head trauma now. Okay, guys?
We have 10-minute break.
ما في بريك الحين. just I will contact Zahir, he will be doing with you. خلاص خلينا ال 10
يلا
minutes.
السلام عليكم يا شباب، كيف الحال؟
Okay.
Because I hear 10 minutes, you can.
No, there is not 10 minutes. Zahir is here
10
already.
minutes from me.
Okay.
I will deduct it from your break actually.
Okay, welcome.
كيف الحال يا شباب؟ إن شاء الله بخير.
الله يحييك، حياك الله أستاذ زاهر.
يعطيكم العافية.
الله يحييك.
طبعا راح نحكي بالإنجليزي for the purpose of the course actually. So the next chapter will be for head trauma. Okay, 1 second بس عشان نحط ال presentation and then we can start. تمام. Okay, let's ask the simple question. Based on your experience, I think you dealt with head trauma previously, and it varies from, let's say, minor or moderate to severe. Okay, so what are the main causes for that? It's reflected in our practice. Okay, so what are the main causes for head trauma?
RTA, falling down.
Okay, hypoxemia. Okay, so we are answering like primary and secondary causes. Let's say, for example, up to my experience or what I faced before was mainly because of motor vehicle accident. Who said falling from high? Okay, it might be. We are talking mainly about trauma. Okay, hypoxemia, yes, hypoxemia can be caused, but if they, let's say, the cause is a trauma. Type. Any other causes for head trauma?
Direct injury.
Direct injury. Okay, yes, direct injury. I mean, from the mechanism of injury, because of trauma, because of falling from height, because let's say we mentioned motor vehicle accident. Okay, fighting. Okay, assault. So all of these cases, like work injury. Okay, a construction area, for example, and those might cause an injury to a brain, the tissue itself, the layers in between. So we are expecting, let's say, a big management, or let's say we need a very close management to the patient. So in general, let's talk before we start our lecture. What are the main management or interventions for this patient or such patient with head trauma? What do you think? Okay, to maintain blood pressure, and yes, excellent, which is an important part, and we'll see this later. Okay, other things.
Stop bleeding.
Stop bleeding. طيب,
Yes.
Let's go to the assessment. Airway, excellent. كله صح. Everything is correct. Okay, but let's reflect it into the assessment, because by tomorrow we'll go, and we are doing like a refresher course for us, because we are practicing this. I will not say on daily basis, but every period or every time Okay, we are facing such case. From where we can start? Let's say we have a case of head trauma. Today you will deal with head trauma, inshallah لا. But let's say today you will deal with head trauma. Okay, from where to start? If you go to the assessment.
Yes. يعني general impression for the head first.
Yes, from the beginning. From the beginning, yes. Yeah, from the beginning. Why? Because you will receive a call like falling from high. We are expecting now potential for head trauma. Okay, there is like a big fight. Okay, with let's say severe cases. يعني. So we are expecting, and as Zaid, you said, okay, from the general impression. So you are finding somebody is lying down, is not moving. Okay, there is like a big rock, and let's say a big machine. So anything can give you an idea. Mechanism of injury. Okay, كريم. ايوه شو رايك كمان؟ انت حكيت لي على الايرواي اظن. Okay, from the airway and stabilizing C-spine. يعني we have combined injuries. Okay, fine. So ABC. That's why ABC important, and we'll see this later. I mean, يعني ruling life-threatening conditions starting from here. After that, you can go for comprehensive assessment and يعني finish your within shorter time. Actually, you can do your secondary assessment. Okay, as discussed with earlier by Firas and Dr. Karima, teachers. Right. So we'll see all of these and those statistics. Okay, they are giving something, but it's not reflecting here what do we have in the UAE. Like 25% of trauma facilities and fatalities. So this is something high, based on the percentage. And cerebral or central nervous system injury, 40%. Okay, which is a big number. It's almost 50%. I mean 40 around. Okay, so we have, let's say, a big death rate. Okay, if not managed. So our role, starting early with death management. I cannot prevent head trauma, but I can prevent complications, okay, before arriving to the hospital. Yes, I agree with you, private transportation, okay, important, instead of staying and spending a lot of time, okay, with no exact management or a specific diagnosis. Sometimes somebody, okay, will miss the diagnosis. So the management will go into or toward different pathway, okay? So what can we see here? I know layers and brain. Okay. What is here?
Anatomy of the brain.
Anatomy, and we'll know later physiology and pathophysiology, but we'll not give more time for that. Yes, I mean, if you look here, you can find. Let's go back to previous lectures. It's like a closed box. Okay. It means, in other words, that if you have a hemorrhage in somewhere, let's say with the tissue, okay, if you see the arrows here, okay, the blood will not go to anywhere except, we have this area. So there is a compression, and that will affect ability the same area, okay? And sometimes you'll find blood going from ears or cerebrospinal fluids. So, 1 second. Okay. Other than we can see those layers. Can we recall them again? It's like a bad, bad. بيكون نفس الغطاء. Bad. Starting from diameter, arachnoid and urameter. So the bleed and the blood can be accumulated anywhere, and then sign and symptom. So remember here that sign and symptom are important. Yani, instead of having an exact diagnosis with no management, I prefer to treat sign and symptom because it's very short time to the hospital. Plus, yani, it will be yani, for severe cases, or complicated cases, yani, very confusing. So go for sign and symptom, and the same systematically. By systematic approach, you can do the A, B, and C. Fine. Look here. So the skull, those layers again, okay, and this tissue, okay, the brain, let's say, floats inside the cerebrospinal fluids. So it might move forward, backward, right? Fine. Go here, next. So primary, I think you mentioned that one, hypoxia. So we have primary and secondary. From the word primary, it's the main cause, direct, hit the wall, for example, or the steering wheel. So we have a direct result of injury, okay? And we have sign and symptom as well. Secondary, so result of hypoxia, for example, we don't have a good perfusion to that area. So that will lead for an injury. Again, a good management can prevent more deterioration. Let's have definition or words. Even we can use it in our, APCR. So it's very important to know. And still, we don't have let's say an imaging. We cannot do CT scan for the patient. And sometimes, unless we have it, that one be introduced to the pre-hospital, which is very important, looking for blood or hemorrhage. But from mechanism of injury, we can expecting the coup, contra coup, and do an assessment. So, for example, okay, Amjad, you will go for the patient and find there is like, let's say, broken glass in the car. So you are looking for coup, for example, the third collision, and it might be contra coup. So you'll check at the back of the head as well. Fine. What contents do we have? The brain, cerebrospinal fluid, okay, plus blood vessels. And those blood vessels will dilate with high CO2 and constrict with low CO2. Okay, it's like mediator and can lead for dilatation or constriction. Right. I would like to pass those, but let's finish from the definition. So why we have those physiology? I remember that, Karim, you mentioned blood pressure, which is very, very important in the pre-hospital, especially for the brain injury. And because we have a shock. So hypertension, a word, when it comes to my mind, I will think about shock. But again, I will think here about a worst scenario for head injury. Right. So ICB, and again, we cannot measure those, but at least we'll work on how to improve the patient status. Okay, how to avoid excessive pressure to the brain. Let's say avoid low blood pressure. So ICB, and we have cerebral perfusion. There's a perfusion to the brain, pressure needed to perfuse the brain. Without that one, we don't have blood going. And the blood pressure, the mean, it means the average of blood pressure. Okay, so we are looking for mean arterial pressure and CPP and ICP. So I'll use them direct without no. Look here. Who can explain this one? شباب. مين يشرح لنا شو الموجود؟ ليش المعدلات طبعا واحنا ما راح نستخدمه في الاسعاف. ليش مهمه؟ ولكن عشان احنا نعرف اوكي كيف نتعامل مع المريض. صحيح. اوكي سيريبرو او اوكي طيب خلينا ناخذ ارقام يعني let's take numbers. اوكي the target اللي احنا looking for اللي هو السي بي بي. اوكي البريشر اللي محتاجينه اوكي should يعني لازم يكون اكثر من 60. we need it ما اعرف احكي بالعربي. محتاجينهم اكثر من 60. طبعا احنا ما راح نقيسهم will not measure that one but how to make sure that we have it more than 60 okay by this equation. يعني blood pressure minus the ICB. أيوة if we have low blood pressure or decrease arterial blood pressure يعني لو أنت أخذت قست الضغط خلينا نعتبر الضغط العادي okay you find it systolic blood pressure 70 or 60 okay this is bad. we need to increase 100 to 110 حتى مرات في الهرنيشن minus the ICB. طب what is the normal ICB يعني less than 50 اوكي بيكون خطير لو كان 50 and more خطير بيكون dangerous ولكن لو كان 25 بصير في عندنا cerebral herniation. احنا ما راح نقيس مره ثانيه ولكن الاعراض تظهر على المريض حنتكلم عليها. So if we have increased ICB dangerous decrease blood pressure mean arterial blood pressure okay again dangerous. It's mentioned here critical so we'll try to avoid that one. طيب.
يعني بالمختصر استاذ زاهر انه نزول الضغط عندنا هو علامه جيده انه اي سي بي مرتفع.
الاي سي بي لا شوف هو يفضل نزول ضغط لا اخر شيء انت اللي بتتكلم عليها اللي هي decrease زائد اي سي بي increase لا بتكون critical. again حنتكلم how to maintain blood pressure we know with the fluids but شو التارجت what do we need عشان نحافظ على البرفيوجن. اوكي لو زاد الاي سي بي البرفيوجن بقل لو قل الضغط البريشر البرفيوجن بقل. اذا ما وصل الدم شو بصير في عندك انايروبيك اذا ما وصل الدم بصير في عندنا نيكروسيس بصير في عندك ديث للخلايا. فتو افويد ذس وان اوكي شو بنعمل؟ to keep this blood pressure maintained يعني constant او ممكن نزيد مرات الاي سي بي decrease. طبعا medically we can decrease that one but with good management حنشوف. خلينا ناخذها increasing الاي سي بي. كيف نعرف انه عندنا اي سي بي increase without any measurement اوكي ما حنقيسها يعني هذيك في المستشفى حياخذوها. طيب respiration increase decrease irregular mainly it's irregular so don't wait to have يعني the injury within the brain is controlling breathing patterns okay so it depends on the location of injury or the pressure of blood or fluids so at what area okay we are having this pressure. So something important I remember that we have noisy respiratory patterns okay بصير في عندنا noisy بصير في عندك hyper هذا بصير عند بعض المرضى اللي هي تروما ممكن تؤدي for death يعني leading for death يسموها noisy respiratory patterns اسمها central neurogenic hyperventilation central neurogenic hyperventilation بصير تنفس سريع بيكون اوكي فيعني هذه الباترنز اللي احنا we are looking for. طيب شو هي نسميها الرفلكس اللي بصير عندنا شوف اذا بتطلع عنا ولا لا اوكي يعني response there is a response what do we call it with that trauma بصير في عندنا increase okay there is an increase for ICB there is increase with blood pressure okay مكتوب عندك طلع عندك blood pressure increase شو نسميها هذه كاشينج ريفلكس اوكي سو بصير عندنا يعني to compensate as a compensation pulse will decrease يعني blood pressure will increase Okay, and we have widening pulse pressure. Do you know what it means? Widening pulse pressure. شو يعني؟
يعني السيستوليك والدياستوليك يكونوا جوا بعضهم.
يعني هو الجسم بيحاول يعمل تعويض بالكمبنسيت للبلد بريشر.
There is compensation mechanism, but will not last for a long time. Okay, so we have a regular increase or decrease breathing. هاي رقم واحد. في عنا البلس is trying to decrease. Okay, the blood pressure which is worse. يعني شو بصير؟ increase blood pressure كمان بصير في عنا وايد زي ما حكى كريم، بصير في فرق بين الدياستوليك والسيستوليك، بصير more بزيد. طيب إذن what will be affected? Level of conscious صح؟ Level of conscious will be affected because of increase of ICP. ممكن المريض يعني بيبدأ ما يستجيب. mechanism of injury بتبين يعني there is a head trauma، بصير في عنا خلص هو there is a decrease and then the patient is going into coma, which is very bad. طيب طب what else? What will happen actually? What are the classic findings when you do your exam for unconscious patient with his trauma? What? Okay, as we mentioned, respiratory problem, arrest, for example. Again, vomiting. Yeah, vomiting might happen because of catecholamine effects, but yani main. Okay, yeah,
seizure.
I agree with you. Okay, because yes, the brain is controlling. Okay, the body, so there is a like paralyzed. Okay, so the patient can't move arms or legs. Maybe on side, it's like stroke. Okay, in one side of the, or I mean, the side of the injury sometimes. And the area affected, the other area will be or giving the response. Maybe the position. So decorticate, decerebrate. Which one is the worst?
Decorticate.
Decerebrate. Okay, arms and legs extended. بيكون مريض extended لبرا. Okay, so everything you need to know, everything to write down. أي ملاحظة؟ نعم. Pupils, excellent. أنا نسيتها. Pupils نعم. We have a dilatation بتكون because of the أعرف ليش difference and the eye deviation ليش بصير عنا؟ The compression وين بيكون compression؟ على nerve number خليها أقل. أيوة اللي هو أي رقم؟ 3 number 3. طيب look here. What can we understand from this one? Aggressive therapy needed for herniation. Remember, herniation. Okay? So hyperventilated is indicated. يعني احنا الحين if you have end-tidal CO2, okay, 30 to 35. Well, like, يعني if it's connected to intubation and it's connected to the monitor, look for the end-tidal CO2, which is an important indicator, okay, for good breathing and placement. So 20 breaths per minute instead of 12 will be, okay, بزيد 20 في الهايبرفنتيليشن. طيب الchildren بيكون أكثر والinfant بزيد. Normally they are more. So remember this one, 20, 25, 20 or 30 for infants. Okay. So the cerebral herniation syndrome is the only situation, remember that, in which hyperventilated or hyperventilation is still indicated. Sorry. What about blood pressure?
maintain the pressure 110 to 120.
Okay, 110 at least 110 بيكون. Okay, remember that. يعني ال target 110 for the blood pressure. طيب facial injury. يعني let's take injuries and then we'll talk about management in detail. So let's say that the soft tissue in the face, okay, of the face is very vascular. أي laceration, contusion على طول بيبين معنا. So it can range from minor contusion. شو الأشياء اللي ممكن تصير في الفيس؟ What kind of يعني when you go to the head you will check laceration. What else? What kind of hemorrhage? Abrasions. أعطوني يلا كمان contusions. You will ask for all of these when you go to the scenario, but in real, immediately you will assess. Okay? So those ones can be fatal. يعني ممكن تكون critical if you have severe bleeding. Other than airway compromise. Dr. Karima mentioned about the airway. The airway is important. حكت يعني if you started with ABC, okay, we'll continue in ABC unless you have bleeding. You need to control. Okay, so if you have like an airway compromise أو حتى hemorrhagic shock, يعني can lead for hemorrhagic shock أو ممكن يصير في عندنا aspiration, obstruction for the airway. So all of these we need to manage. The management, for example, secretion, suction for secretions. The question now, most of bleeding can be controlled by direct pressure. Sorry? Do you think all bleeding will do that one?
Not all will be all.
Okay, management direct pressure, but not for everything, not all kind of bleeding. So what other fracture can be happening? If you have fracture and bleeding to the face, not the head.
Jaw fracture.
Jaw, excellent. What about nose?
Nose fracture.
Nose fracture. Yes, nose bleeding and fracture, but that one, based on statistics, will not lead for severe hemorrhage. Okay? Right.
Teeth also. It's compromising the airway.
Okay, but look now. Scalp wound and the management, everything we have a management for it. Okay? Let's say stop bleeding based on your scope practice. We have different techniques, ways to stop bleeding. Depends on the location, the application of it, okay, contraindication and indications. Right. Before, or what came to my mind, I think one lecture will be with Dr. Karima, children, okay, the scalp wound, because of they are playing and they can hit the head, throwing objects to the head. But remember that when you do your assessment, we can suspect abuse with no clear explanation, of course. Okay? لو احنا كان عندنا طفل ممكن just think about any abuse إذا ما اقتنعت بالmechanism of injury. طيب. Any questions so far? So again, because of highly vascular, okay, avoid shock here. Try to avoid, especially for children, and look for other causes for adults. Okay, so we have different kind of injuries. The skull itself can be injured, fracture. So the fracture, that one is different than, I mean, in different scenarios. We have, I don't know if you had like an impaled object to the skull before. Did you deal with such case before? For me, not. The breast, maybe. Linear, but again, you cannot assess. You need a close assessment with light and then look to the skull. I mean, the skull itself. So it might be the breast compound with more, place. Okay, it might be small or large. Again, management, how it will be. And I started with airway. Okay, manage the airway, breathing as well, circulation, if any bleeding to the head, okay, is important. Severe bleeding, we are expecting shock. Vital sign, hypotension is dangerous for the herniation. And then you will proceed for decision, and after that, vital sign and head to toe examination if it's not clear. So with head to toe, I will start with the head, okay? And if it's life-threatening and severe, I need to stop and manage it. Otherwise, I can delegate tasks to my colleague, okay? They can finish. They need for help, they will do it. Right. So do you think a direct pressure with compression? We'll try. Carefully, you'll dress that one, but sometimes I cannot press. Okay, if there's an object, what you'll do? How to manage an object?
Dressing.
Dressing over
the object is key.
If there's an object, piece of wood or stick or, okay, try to stabilize. Yeah, stop bleeding with stabilization around the area. Fine. طبعا هون we have different terminology and causes. We cannot still we need an imaging to have a proper diagnosis and management, but still we can look for sign and symptom, how the patient is act or reaction of the patient. Okay, concussion, for example, بالعربي ارتجاج. So there is no structural injury to the brain. There's an accident, he hit his head, cope or contra cope, the patient, okay, felt dizzy, let's say, but still conscious. Okay, there is sometimes when you ask the patient a short-term amnesia. Okay, بشوي بفقد الذاكرة. فthe patient ما بعرف لو مرت معاكم تسأل المريض كيف صار حادث بحكي لك أنا ما بتذكر. Okay, so the patient cannot remember because only shorter time. Maybe after that he will recall, try to, okay, or when he or she looks to the area, oh, I remembered. So this one for shorter time. Okay, so what other associated symptoms? Everything related to the head. So because the head is controlling the nervous system, the movement, the sensation, okay, and some vitals organs as well. So you find it reflected other place. Nausea, كريم حكيت nausea, maybe vomiting. Okay. ممكن نسمع صوت، بسمع رينجينج بتكون زي صوت صدى، زي حتى الصوت بيكون مش واضح بسبب الضربة، ولكن it's only for a shorter time. Again, we cannot underestimate. بسمع أي صوت بالضبط ما عندي فكرة، ولكن there is the sound is like more than one sound. Okay. It might be worse, going to be worse. فلازم we have to open an airway, okay, manage the breathing with good oxygen, okay. If there's vomit, the position, all of these. Sometimes the patient will be agitated and put in your mind everything might happen. We cannot underestimate even concussion. ممكن تكون less worse, but we need to give more or close assessment, let's say. طيب. contusion. Again, we cannot see that one. But what will happen actually? There is a bruise to the brain tissue. Hopefully, this will not happen to anyone. I mean, if you have a cold. So swelling, bleeding, okay? It depends on the degree. So it will be rapid and severe. Here, there is no like shorter time of consciousness, loss of consciousness. Maybe it will be more, okay? There is longer for the confusion. Yani, some patients will be transported or treated, and they will stay in the ICU after even they ruled out trauma because of level of conscious. And after, let's say, 1 month, okay, they will be rehabilitated and come back. So maybe they will not remember even what happened. What other signs? Okay, other signs: weakness, as we said, muscle problem, speech problem. Okay, it's not a stroke, ولكن the area of the speech was affected. Vision sometimes. Okay, so we cannot hear to be in conflict with a stroke. Again, mechanism of injury is important. By brain injuries, here, those they are like a very deep in the medical, diffuse axonal injury. But let's go fast for it, okay? And the most important, how to deal with sinus symptom, based on your scope of practice, let's say, how to manage the patient with head trauma. So we have, because of injury, okay, the area there is having like an edema, accumulation of what? Fluid? Cerebrospinal fluids. Okay, there's a fluid. Unconsciousness. Every time look for level of conscious. AVBO, as Firas said, and then we have a time for Glasgow scale, which is a good indicator. Okay, we don't have other deficits here. But again, let me go for this one. Anoxic brain injury. There is a problem, there is a spasm will happen, okay? And we need a good, perfusion to be started early. So here the time is important. How to do that? After 4 to 6 minutes of anoxia without any oxygen. So cells itself need oxygen, okay? That oxygen is transported by blood. So what do we need here? We need fluids, okay? We need to maintain blood pressure. So we have a good perfusion, cerebral perfusion, plus oxygenation. So with airway, open the airway in a best maneuver or intervention needed for the patient, and start with fluids, okay? So interventions will be early as soon as possible. So if not managed early, if we didn't start with good oxygenation and pressure maintenance, maybe we'll have bad results, okay? Worse results. Fine. What will happen actually if you have a hemorrhage in between layers? It's very similar to stroke, okay? Ischemic stroke and even hemorrhagic stroke. So might we find sinus symptom? That's why if you have like a level of conscious decrease and there's like, okay, there is like when we go for differential diagnosis and we don't know it's like a trauma head injury and we don't know about the mechanism of injury, okay? So how to rule out? We have an exact assessment for stroke for the patient, and we can look for example, blood glucose. Who knows? I mean, for level of conscious, if you have decreased level of conscious, what other assessment do we need? يلا اسمعنا.
Blood sugar assessment, maybe it's hypoglycemia.
Yes, blood glucose is important here, and sometimes medical will lead for trauma. So glucose level of conscious, how to assess that one? Glasgow Coma scale. Okay, it's not the overall scale. I mean, not the overall score. Take it one by one. So then you'll find the problem. And what else? And the vital sign. What you will assess?
Blood pressure, maybe.
Okay, by default, we'll take blood pressure. Something important for the head trauma. Head trauma with level of conscious decrease.
Pulse pressure.
Pulse pressure?
Yes.
Again, we mentioned that earlier. حكينا عليه لما كان في head trauma. حكينا بتصير focal signs. بتصير في عندنا compression. Compression will be on the nerve. Number 3.
The pupils?
Dilated the eyes.
Yes, excellent. Okay, pupils reacting
Pupils,
equal
pupils.
the size. Okay, فهذا مهم جدا at any time for head trauma. دكتور كريم إذا خلص الوقت بس ممكن تحكي لي. أنا ماشي بطيء كنت شوي. طيب acute epidural.
Take your time, Zach.
Acute epidural hematoma. So all of those terminology they are يعني tough and difficult, but إحنا to have an idea mainly, but the management will be for the all patients. Okay, so EB above the layer itself, above that layer, there is a bleeding. Okay, because for any, let's say, any reason, Fine. So with acute epidural hematoma is let's say, يعني, because of the tear, let's say, tear in those layers, okay, or meningeal artery. And if you look here, this is the artery, middle artery. So for any tear here, the fracture is here, the injury is here, okay? So what is the area here? What do you call this area? Temporal bone, okay? This one is very يعني easy to fracture. لو واحد أكل ضربة على هذه المنطقة يعني بسهولة على ممكن يصير في إصابة في الارتري. طيب. So we have arterial bleeding. It takes minutes to hours. And شو بصير عنا؟ Increase for the ICV. Again, that one for the area is closed. ICV increase. طيب. شو symptoms بصير؟ Again, when we say increase with the ICV, we are expecting some symptom of increasing like vomiting, headache, mental status. Okay, the patient will go for unconscious or let's say altered mental status. Let's say weakness, paralysis to the other side of the injury. يعني هذا مثلا left بصير على right side. Okay. Again, sometimes we have dilated and fixed pupils even. هنتكلم عليهم كمان شوي. Pupil on side of head injury. طيب. Here we have venous bleeding. Okay. And that one is artery and venous. What is the difference? This will take more time, hours to days. Level of conscious يعني fluctuating بيكون between. ولكن mortality is high. طيب high risk alcoholics يعني طلعت بلاغ كان عندك if you have a call for elderly ولا واحد كان alcoholics. اوكي شو بصير عنده injury we are expecting حسب هم based on the data they are having internationally expecting that alcoholics اللي هم اللي بياخذوا الكحول ممكن يتعرضوا لهيد تروما وحنشوف في المحاضرة later. اوكي فبصير في عندهم البليدنج واكثر الاشياء اللي بتصير acute subdural sub يعني شو تحت شو الديورا في above في below. اوكي بس عشان نحفظهم بي فوق الديورا اللي هي اخر طبقه السطحيه مع السكال. اوكي والسب ديورال تحت فالابوف الطبقه اللي فوق بتكون شو ارتريز اللي تحت بتكون فينز ميبي. الاشخاص اللي بياخذوا انتي كوجولانس they are taking anticoagulants they are يعني with high risk for bleeding كمان يعني كل هذه الاشياء تلعب دور. Okay now with the intracerebral hemorrhage بغض النظر it might be artery or from the venous. طبعا here we cannot do it. The patient may be completely unconscious. Okay again we'll ask about mechanism of injury. How might this happen؟ كيف صار هذا الكلام؟ كيف صار؟ هل هو falling يعني صار في عنده from high يعني what are the symptoms associated symptoms. Okay هذا ممكن نشوفه يعني it's very close to the stroke with severe hypertension. إذا بصير عندهم headache بصير عندهم vomiting كل هذه الأشياء. طيب شو السيمتومز اللي ممكن تكون حكينا عليهم أو حتى السيريبرال هيرنيشن سيندروم ممكن يعني بصير في عنده increase في الاي سي بي there is irregular breathing patterns. اوكي الايز فعندنا مشكله في اللي هو اوكي الليفل اوف كونشس. طيب انا حمشي اسرع على هذول اللي هم سباركانويد حسب يعني مش حنحفظهم طبقه طبقه ولكن there is a leak. Subarachnoid it's at the middle. Okay so we have a leak into brain. This will go to the brain. It's not مش هي السطحيه superficial. It's going down now. So it will lead for edema. Again we cannot find يعني we can look for this by imaging assessment. طيب so as we mentioned you'll do the head assessment or head trauma assessment while we are going for initial, primary and secondary. Okay. طيب the question for all please, what is the main management? يعني with Dr. Karima the airway we did the management. Okay so we are expecting vomiting fluids. How to manage that one? We need to open the airway for unconscious patient. What are the main let's say basic or advanced? Okay maintain C-spine stability one of these interventions. Okay طيب and remember that we can
maintain ventilation also for
maintain blood pressure. شو كمان نزيد؟
ventilation.
Okay انت قدرت CO2. So let's say before we start endotracheal intubation we need to pre-oxygenate the patient. Okay and then done okay open the IV as we said early intervention is needed. يعني احنا بنمشي ABC but it's okay. So pre-oxygenate yes yeah okay the ABC. So the airway managed as well. Yeah Yes. So if you look here, drug-assisted intubation, if we يعني, will be a part of the team. And sometimes will not go because of scope of practice, but medication sometimes will lead for hypoxia. Okay, that's why they yes. Okay, that one is an important intervention. Type. Sometimes for let's say children, we prefer if you have good chest rise, good bagging, خلاص, no need for advanced airway. So let's have more interventions. Okay, to the face. When you started your head-to-toe examination, don't rely on those, but they give you something. Battle sign, Raycon eyes. Okay. Base skull fracture, basilar skull fracture. Yes. Okay.
This is the late sign, it's not the early sign that we can see it in the
Yes, late sign. So what will happen actually? Bleeding from ears or nose ممكن يكون عندنا. بيكون عندنا clear cerebrospinal fluid coming from the nose. مرات swelling بيكون زي ما حكينا behind the ear, battle sign والرaycon eye. Okay. طيب raycon eyes are sign of what kind of fracture?
skull fracture.
occipital.
Sure. Yes. Okay, because let's say blade in the upper nasal cavity. So there is a leakage of fluids, but spinal fluids. Mainly it's anterior basilar skull. they are basilar skull, but في anterior and base. This one from the anterior basilar skull. Okay, this one recognize. What do you think? The question now will go for OBA or MBA participation.
We avoid the MBA in this cases too, because it's
yes. So it's contraindicated to insert nasogastrectomy or MBA or sometimes they are doing, I don't know if you have it or not, nasotracheal intubation, but here is not indicated. Look here. Again, this is we discussed before. Third cranial nerve. We have bilateral, we have unilateral when you go to assess pupils, okay, and it might be because of other causes. Okay, so pupils are controlled in the part of third cranial nerve, as we agree. Okay. So if both pupils are dilated and do not react to light, the patient probably has a brain, say, stem. Okay, we have mainly من مركز المصدر الرئيسي brain stem injury يكون both eyes. Okay, so bilateral. But if you have unilateral dilated pupil that remains reactive, still reactive to light, okay, maybe it's an early sign for ICP. ممكن يكون bilateral but still reactive. Okay, that's why we are looking for reaction and equal. So what other causes? What kind of drugs? Give me an example. Drug effect.
Opioid.
Excellent. Atropine. Yes. So maybe a direct trauma. Okay. You are facing like a trauma to the eye. So we need to protect the eye if we can cover the eye or use the plastic sheet. So here we will not test for this patient what we said before, corneal reflex. بنجيب gauze ولا tissue. It's no effect for testing for blinking يسموها. فما في أي فائدة منه. ولكن we look by the light, pin light from the side على pupils how they are reacting. Okay. Again, if you assess and you have long time to the hospital and we are expecting head trauma, don't say خلاص one time. We have reassessed for the vital sign. So reassess pupils again. Maybe it's an early sign. Okay. and later we'll find different response. So here, as we mentioned earlier, extremities decorticate from the name, from the cortex, superficial, decerebrate from the tissue itself, من النص جاي, من inside the tissue of the brain. Okay, so the second one is herniation, treated as herniation. So we'll go for fluids, good fluids. We'll give high oxygen or ventilation. Okay, so here flexion or flexed arm, and here extended. Okay. Fine. What else we can add? So the decerebrate posture is very worse, and let's say it signifies herniation, cerebral herniation. Okay, and hyperventilation is indicated. طيب, any questions so far? Again, don't forget here when you see such patient to do the BMS. When it's indicated, so okay, again, if we recall the sign and symptom, what cause? And أول شيء we'll go for mechanism of injury. Sometimes it's minor. We have, like, let's say a fight between two persons, and he hit the head. There is like a degree of pain, but it's very minor. The patient still cooperative, is conscious, no loss of conscious. يعني ممكن تحصل مريضك conscious, صح؟ ولكن if you ask the patient, he will tell you that I lost my conscious for a few minutes. So for this patient, it's very minor to moderate. There's no loss of conscious, no sign of herniation at all. Only we'll think about herniation. So herniation means that we have irregular breathing, صح؟ أما مريضك بيتنفس طبيعي وعنده شوية صداع، هذا مريض ما يحتاج. أوكي؟ في الحالات هذه. بالضبط. لما تتوقع انكريز الاي سي بي مع اذر ديسربريت mainly. اوكي، يعني هاي الصوره رقم بي هي هاي الاهم اللي نبدا فيها. اوكي، اللي هو الهايبر فنتليشن. again Glasgow scale is important as well. هلا نشوف. اوكي، Glasgow scale شو بنعمل فيها؟ as we said we'll take it each part itself. Okay, عندنا different, يعني عندنا for adult and this one sometimes is difficult to يعني to memorize. Okay, so keep it with you. If you have it with the ABCR, go and يعني don't put number, and because it's very important for triaging. Again, look for the brain or severe brain injury if the Glasgow scale is than 9. Okay, يعني هذا ممكن يجيكم في الامتحان. والله less than 9 I will check brain, يعني expecting severe brain injury. So this one also give you an idea about herniation. Less than 9. طيب, look here, level of conscious decrease with head injury. And the shock, يعني sometimes we have another cause of what happening for the patient. So for me, I will go for mechanism of injury. What other causes? Or let's say head-to-toe examination, a very close, okay, assessment. So level of conscious for both will decrease. Respiration, عندنا مشكلة في الريسبيريشن في الهيد انجري. اوكي، fluctuating، ممكن ينزل ممكن يزيد. طيب، في الدستريس او في الشوك بيصير في عندنا increase في الريسبيريشن mainly. البلس والانكريز. اوكي، طيب بس هذول ممكن تعمل سكرين شوت. The blood pressure mainly decrease but here increase. هذا الاي سي بي عنده مشكله هون. فالانكريز blood pressure remember بلس بريشر بصير وايد عشان بصير الفرق واضح. اوكي، again for fluids, another time for fluids. Look here, طيب hypertension it's fatal يعني dangerous. Okay. طبعا again the child تختلف. احنا cut off point for the adult is 90. The child around 10 years. كيف نعرف البلد بريشر؟ اوكي بناخذ ال 1 to 10 years 70 بلس اوكي ال 18 years يعني عمره سنتين مثلا ضرب كم؟ 2 يعني 70 بلس 4 اوكي 74. هذا بنسميه المينيمم اكسبتد. The minimum accepted for the low blood pressure. So the systolic blood pressure is fixed for the adult. For the children, okay مرة ثانية 70 plus 18 years time 2. اوكي بتحسبها بتشوف المينيمم اكسبتد من 1 to 10 years. تحت ال 1 year 70 نحسب. اوكي traumatic brain injury تحت التسعة هذا بنفكر في اللي هو الهرنيشن. نبدا بنعمل له blood pressure with the fluids نعطيه titrated يعني بنحاول نحافظ على هذا الرقم مش نعطيه fluids keep it open all the time. لا احنا we need a good perfusion. ممكن يصير في مشاكل ثانيه وعطينا fluids more than needed. ممكن يصير في problem with the breathing. So with or without penetrating hemorrhage. حتى لو ما في hemorrhage ممكن نعطيه to control او maintain اللي هو السيريبرال بريشر. اوكي اللي هو كم كان السيريبرال بريشر مين بيتذكر؟ كم كان؟ لا السيريبرال بريشر المينيمم يعني. لا هذاك الاي سي بي. اوكي السي بي بي 60 ل 70 بس احنا ما راح نقيسه فهو مش مطلوب مننا. طيب secondary now with the secondary we need okay head-to-toe examination. We'll do our assessment as we mentioned. Any trauma we'll manage that one. Okay we'll go for management for bleeding, stop bleeding. The history will done vital sign and يعني we'll make comparison between اللي هو first set of vital sign second set of vital sign. Good oxygenation. Okay good ventilation if needed. There is no good chest rise. The patient cannot control irregular breathing. It's very fast, very fast. Okay, we'll go for ventilation. So oxygen as well, yes, for any trauma, we'll go for 15 liters per minute. Okay, if needed only. And we'll check for saturation. Saturation 94, 95 and above. In such cases. What else? Okay, so end-tidal CO2, if you establish that one, so end-tidal CO2 will be 35 to 45. Okay, herniation حيكون حيطلع لنا أقل شوي. طيب endotracheal intubation for adults mainly. So we are treating the cause. Okay. طيب. Any questions so far? So we can add to this one spinal management. حيكون عليها we have a part for that one. Restrictions يعني again the brain is affected. The result will be for example agitation. Okay, so يعني restrictions we needed. Less movement because maybe the neck is injured, the spinal cord is injured. So we don't need further complications. Okay. Anytime we'll have baseline observation. So don't take the vital sign one time and that's it. Every how many minutes you do your assessment? If you go for reassessment? Every
5 minutes. Maximum
every
5 minutes.
Yes, especially if you have long distance to the hospital in Dhafra, for example. So every 5 minutes you are doing your assessment again. طيب. Okay, so nothing to add in the summary. We need a good management to the airway with oxygenation and ventilation for the circulation to prevent and avoid hypotension, and a good reassessment. You will go for vital sign. Okay, you will assess again the. And somebody will say, okay, why to assess glucose level? It's very important. Okay, if you have the time, go for even ECG. But I think the most important, okay, to look for those first, and then if you have the time. But I think for such patient, if it's like severe, you don't have the time, okay, to do other assessment, normal one. So reassess important, and at the hospital, let's say if there is any intervention, check before and after. Remember that the patient condition is important. Is the patient responding to the oxygen? Is he responding to your fluids? Okay. Okay, is responding, but in which way? The good or the bad? Okay. So the bad is because of breathing is now getting worse. I need to stop. I don't want to treat something and have another problem, but I need to treat the most important, okay, the life-threatening conditions. If there's a fracture, just leave it. Close the fracture with no bleeding, for example. Okay, just focus on the how to stop bleeding to the head, how to give fluids, how to manage the airway. Okay. If no, any question? Thank you.
يعطيك العافية.
الله يحفظك.
يعطيك العافية أستاذ.
Then I think you need 10 minutes break now.
Okay.
Yes, we need a break.
So let's take 10 minutes and come back for the next.
Okay, thank you.
Okay. Thank you. يا حرام نايم هذا ليش نصحيه؟
خلوه نايم خلاص. We start at 12, right?
أظن والله أظن
خلاص نتريوا شوية 3 minutes 3 more minutes.
إن شاء الله.
Hello again. Are you here?
Yes, yes.
هاي دكتور.
Helene. I know after a huge lecture, which is head trauma, do you have any headache? ولا الأمور طيبة؟
أكيد.
We will do now the pediatric trauma. شفتوا من الهيد trauma نمشي الكتاكيت احنا الحين البيدياتريك child.
دكتورة خليه ينام، ما فيش عاد صحي هذا، خليه ينام.
خلاص ما حنصحيه. We will work with him very smoothly. It's okay, we can start.
Yes, we'll go.
اوكي ان شاء الله.
Okay. هنا نسمعوا أطفال صغار الحين موجودين معانا. Okay. Usually we are working with adults generally, right? معناتها it's a few times when we are dealing with kids and with children. And all the time, the kids and children, they are not by themselves. We all the time facing parents, facing the nanny or the other family members. We will try to see how we can deal with all these circumstances, and we try to demonstrate or to recognize if there are any potentially life-threatening injuries for this kind of patient. Do we need a special equipment? Do we know how to deal with this kind of situation? All these things, we will see them through this lectures. Inshallah, it will be an interactive session. We will discuss, and it will be going smooth. They're talking about differences between an adult and a child. Who can tell me which kind of differences we are just facing when we are dealing with pediatric patients?
The head difference between adults and children regarding the whole body.
صحيح. الهيد سايز معناتها anatomical differences between the kids and the adult is, for example, the size of the head. Usually it is bigger than the body, and sometimes also the organ size. The organs are already inside our body, the kid's body. They are bigger than the sizes of the organs and the head of an adult. Right. They are talking about the difficulty also to assess and communicate. Where is the difficulties? Where can we find these difficulties?
The pediatric cannot complain.
Yes, usually they cannot complain what they are doing. Instead of complaining, what they are doing?
Crying.
All the time they are crying. They will not give us any information. The only thing they are doing, it is crying if they do have pain, or if they don't have anything, they will be just restless. They will be just, flaccid, without any movement. This is why it is difficult for us just to assess them and to know what is happening. And one more thing, it is that they are not by themselves, they are with the parents and or other family members, sisters or brothers. And usually when they saw that something is happening to their kids or the child, they are just screaming, they are scaring, they don't know what to do, and they will put you in a hurry. They will put the stress on you.
صديقي هي أسئلة ITLS.
الو نعم معانا الاسئله
سوري دكتوره.
It's okay. نعم تبع معانا تروما بيدياتريك تروما بعدين شوف الاسئله. Okay, just to have an idea concerning the big differences is already the anatomical differences, which are the head and the organ size. Of course, there is other differences, which are the airway structures for the kids. They are different, okay? And sometimes we need special equipments also. The difficulty to communicate is sometimes these kids are just crying. They are not giving us any information. And, we are less comfortable treating children because of these differences. And of course, usually the fact that children sustain already severe injuries, then less than for the adult. We are saying all the time it must be serious cases for the kids. And of course, the third thing is that they are coming with their parents and with their family, and the parents and family are all the time taking care too much concerning their kids. And this is why they are asking us also to have more competencies and more care for their kids. Family-centered care is critical where? Because we can see here in the Gulf regions that the kids are not by themselves, they are not with the parents, they are with the caregiver. Okay, and the caregiver cannot give us the right information for the kids. This is why we have to deal with this kind of situation, and we have to involve the parents as much as possible. Okay, how can we involve them? How can we know that they will be just accepting our work with them? Usually, the best method to gain confidence for the parents is to demonstrate that you have the competency and you have the compassion in managing the child, okay? The parents, when they saw this, they will be more cooperative with you. Then to demonstrate that you are able, you are the team leader there, you know what you are doing. And of course, with this, you have to show them the compassion that you know that it is very important for them to take care of their kids. And when you are showing all this, you will gain the confidence of the parents, okay? And sometimes you can just involve them for taking care of their kids, okay? Of course, we are talking about inclusion and respect. You will not go shouting for the parents or shouting for the kids. This is important to show them this compassion. Like this, they will be just with you and they will help you on taking care of their kids. One other things here, we are talking about communication with the kids and how can we deal with them. Usually, when we are just assessing a patient, we will start by the mental status, right? How can we know that the patient is having a good mental status or an alterated mental status? Usually what they said, if you can console or distract a child by a person or by a toy, it means this person is having a normal mental status. If the kid is just intercostal
assessment. Okay, يعني we'll do initial assessment or let's say the impression. Okay, we'll go to the patient. You will look for any bleeding, صح? Any bleeding. If any bleeding, you need to manage. And let's say it's closed, so no any other injuries. So airway, breathing, circulation. In which part you will assess extremities?
Secondary assessment from head to toe.
In the secondary, yes. Okay, to extremities. Fine. Yes, at that part, unless we have an open fracture and there is a bleeding, okay, we need to control. Fine. Okay, so let's say this is your case. You have such patient with a sprain or strain, okay, sprained ankle, for example. And do you think we'll go for general assessment every time, or it might be like focus assessment only?
Focus, it's only this injury, focus assessment.
Okay, but if there's like unconscious patient with unknown history or mechanism of injury, we'll go for maybe
General assessment.
General one. Okay. So what kind of injuries to the extremities? What do we have? Look here. And this in your experience or cases that you attended before. Okay. What kind? We have fracture. It's not only fractures. Sprains.
Strains.
Strains. Okay. Yes. Excellent. Object. It might be severe, like crush injury, amputation. Okay. Compartment syndrome. All of this. Yes. Anything else we can add? بعد الغداء طيب يا شباب. So let's continue with the main subject. It might be normal, I mean, easy to manage. Sometimes we delay into the ambulance, okay, while we are transporting the patient. If you have other combined injuries or trauma or management, we need to provide. Or sometimes we can spend more time to do the management. And as a result, okay, we are expecting. And sometimes if it's severe, there is results, like what we said previously, shock. It might be hemorrhagic shock. Maybe, what other types of shock? What about mechanical shock? Okay, an injury to the lungs. And there's a compromise. And if you have a patient with BMS, which is difficult to detect, it means we need a rapid action. Okay, so look here for fractures, we have different types, open and closed. And we can differentiate between each one. And we can see the wound outside, it's open, the bleeding is going out. Okay, but the pain is, there's a pain.
زاهر ما في صوت عندك راح.
فصل البث كأنه
الصوت راح يا طيب.
لا
بس
ممكن
الصوت
عن
عند
زاهر
زاهر راح. يمكن اظن انه الصوت عنده كان مش شغال وطلع وهلا حيرجع يدخل لحظات الحين يدخل. لحد بس ما يرجع مرة ثانية للتذكير فقط مشان بكرة. بكرة طبعا حيكون الساعة 8:30 في كلية فاطمة. لما تدخلوا على البوابة بس خبروهم إنه إحنا جايين منشان تدريب جاهزية، وهم بيدلوكم وين تروحوا. حنعمل ساعة نظري، بعدين حنبدأ في العملي والتست آخر شيء. متوقع إن شاء الله نخلص على الساعة 2:30 تقريبا.
أستاذ فراس، بس نيجي باللبس العادي صح؟
اللبس العادي؟ شو اللبس الغير العادي عندك؟
لا يعني
لا،
مش
يعني
دريس،
مش دريس.
مش دريس الشغل.
لا
بس
لا، لبس
عشان
العادي.
التأكيد. بارك الله.
لبس العادي.
اوكي سوري فصل
اوكي فراس سامعينك. زاهر سوري.
نعم. اوكي طيب. اوكي واضحة الصورة شغالة؟
يس
نعم شغال.
Okay, so sure. So a fractured pelvis can cause, let's say, extensive bleeding to the abdomen. يعني مش بس هو بس في it's not only for the femur, even for the below quadrants. I mean, right and lower, you'll find there's distension and pain, and that might be because of fracture to the femurs. Okay, so if we have angulation, I mean, there is like movement for the bone from its place, and there is a pulse which is absent. You cannot feel the pulse. What shall we do?
Traction.
traction, so we need to do or apply gentle traction. Again, we'll go for scope practice. I think that one, the traction, the manual gentle traction, it's mentioned there. So can be applied, yes, we can do that. So if it's still, or let's say we have a resistance, okay, can we do the traction or try to apply more weights or force, let's say?
Maybe if more traction, maybe make the neuro cut.
Okay, and other thing is complications might happen. So we'll try to do what? If read it here, it's blend in the most comfortable position, okay, and rapid transportation. The same position, the same position. Okay, if the patient on the stretcher and you cannot, or I mean the previous ambulance, I remember that one case. Okay, we cannot take the patient from head to toe. I mean, from head is first and then legs. So we, put the patient at the opposite side. So legs first, and because there was no space, and we split the arm with the same position. So he was in the opposite side. Type. So for injuries, we discussed or talk about applying tourniquets if there's a bleeding. So remember that if there's a fracture at the same time, you cannot apply above the area. Or let's say 2 inches maybe will be difficult. So we'll go above the joints, okay? And the idea is to cut the blood supply. Okay. So otherwise we can use homeostatic agents. I think if you can use that one instead, would be better. Okay, open wound, the same thing, wound management or bleeding management. Okay, if not managed, it will be life-threatening. So if we cannot stop with pressure, with tourniquet, go for homeostatic agent, we said that one. But be careful about any contamination. Okay, if anything, we can do irrigation. I think yes, using normal saline. Bring the saline and try to irrigate the area. No need for special substance for that if you don't have. So here we cannot delay based on the amount of the blood the patient lost. Type amputation. We have all equipment. In the ambulance, the ice. Okay, what else do we need?
If the extremity completely amputation, put it the part in the bag, special bag.
Okay, excellent. So stop bleeding first. Amputation bag. Okay. If you don't have, we'll go for the normal, the one we can. We did it before. We were doing only plastic bag, and be careful. Don't put direct the ice too. Okay. Try to wrap the ice. Keep it in the water. So yeah, it's here. Okay, writing the time and keep it in a cool temperature, not warm or hot. Okay. So we know how to do the management for amputation. It's very easy. And once we apply an intervention like traction, we'll check the neurovascular, let's say, and vascular supply. So we'll look for pulse, motor, and sensation. Okay. Sometimes it's weak, and sometimes we cannot feel because of the fracture. So for the intervention itself, if we apply the traction, we'll do before and after. Okay. So tomorrow we'll practice this one. Don't forget pulse, motor, sensation. Okay. Reassess. It's not only one time. Reassess. Sprain and strain. We can differentiate between. We know the sprain, mainly for joints and ligaments. Okay, both they are having pain. Those we are stating as fracture. But if you want to differentiate something or one for muscle and tendons, okay, strain and sprain يعني التواء يكون mainly to ligaments and joints. Okay, objects the same for extremities. I mean objects in extremities. Make sure it's not obstructing the airway. يعني if you have a protocol to remove it for the airway, we'll do that one. Okay, and for other parts, keep it, stabilize. We can use the donut, the old technique. Okay, and then we can bat, putting bats around, and then tape with a tape. Okay, that's it. I think it will be very easy. So stabilize at the same position. Again, if you talk about compartment syndrome, so this might happen as a result, complications. And if you look here, we have starting with P letter. Okay, so 5 P's. Some texts they are adding 6 and 7. So if you look, mainly we have a pain, early symptoms, pain, paresthesia, يعني feeling of numbness. Okay, late symptoms, even this one will happen with like let's say a high pressure, a strong pressure on the extremities. So late symptom, the same thing, adding failure. يعني مثلا عملنا أي procedure أو it might be under like heavy weight, pulselessness. بيبطل في pulse. لما تشيك BMS, there is no BMS or pulse. Paresthesia, we said numbness, paralysis أو weakness بيصير على الأطراف، بيصير في عنده ما بيحرك، عدم قدرة. So it happened for forearm and lower legs. The common one. بيصير فيه swelling. Okay, this will lead for a compression over what? Nerves and vessels. فما استفدنا، ببطل فيه blood flow. شو بصير في عنا necrosis, an aerobic process. Okay, this is what we call compartment syndrome. Other term we are using, بتركزوا عليهم. Okay, crash injury. Okay, for extended time, for longer time, under نفس ما حكينا construction area, heavy weights on the arm or leg. Okay, there is an aerobic metabolism. So what we'll do? Okay, هل حنعطي fluids? We'll give fluids. What do you think? Toxins will be distributed. صح؟ Yes, ما سمعتها. Okay, when extrication is complete and blood flow from the crushed tissue is let's say stated, yeah, بدينا. Okay, hemorrhage from crushed tissue and toxins produced in crushed tissue شو بصير distributed throughout the body. And يعني again, let's say we have potential complications. So this complication or these complications will release, as we said, lactic acid. شو في عنا? What other things? Uric acid, potassium, phosphorus. Okay, and شو بصير عنا? Will happen. يعني we'll look for ECG because we are expecting cardiac dysarrhythmia. Okay, في عنا potassium. We have potassium.
بصير arrhythmia بال-ECG.
Yes, excellent. Arrhythmia, and there might be severe kidney damage. Okay? So sometimes they are providing or trying to do, if you look here, alkalinization. ما بعرف, I'm not sure if we are trying to do something within our scope with sodium bicarbonate. And they can start sodium bicarbonate to equalize this one in such case. So حكينا, we said anaerobic. Okay, we have toxic lactic acid as an example. Okay, يعني for ischemia, if you look to the picture, extremities they can tolerate up to 4 hours. يعني we'll find it different. Some will say 2 hours. So 4 hours, let's say, with ischemia, with no oxygen, with no blood supply. Okay, and after that we have compromise to the circulation. Okay, so if possible, we can say fluid administration before we are pulling or taking the patient from the collapse structure. And immediately start. If you have resources, yani we have the people or more than one, okay, at scene. So look as an example, mechanism of injury every time. And what kind of injury? So from mechanism of injury, MOI, even if you didn't see the patient before you arrive, you can expect, like sitting the patient inside the car. So what kind of injuries? Okay. So shoulder involved, shoulder, pelvis, okay. And if you look, for example, to the vehicle and find, okay, that like right side, left side, front, back, rollover. So everything will give you an idea about what happened or expectation. So the same thing, controlling bleeding, okay, avoid an infection or further infection. Try to manage fracture to pelvis, okay. Again, stability, for example, stability. So when you're trying to, for example, examine the arm, there's like stability. It's not stable. Cavitation, the bone sound, cavitation. So sometimes in the joint, okay. So we need to splint most of the time. Splint. How to splint? Different techniques, different ways. Okay, what we are using? Normal splints. What do we have?
Vacuum splint, foam splint.
Air splint. Do you have air splint? Are you using?
Vacuum splint.
Vacuum splint. So we are trying to decrease, prevent. We cannot prevent totally, but minimize movement or motion. Okay. And avoid any complication or more complications, decrease the pain, like for example, arm slang. So will not delay, will not say, okay, even it's close fracture, just spend more time, more 20 minutes at scene. No, we can do any things in a way with no harm to the patient. So let them go. We'll talk later about backboard. And sometimes we'll need more stabilization or splinting. Okay. So be careful. I mean, when you do splinting, visualize. And you look for the injury. If there's a blood or bleeding, don't cover. Okay. I mean, don't cover with the splint, but you can cover with dressings. So below and above. Below and above. Remember that the joint. You can use them. You can splint two legs together at the same time. So different techniques. We know all of this.
استاذ تقصد انه ما نغطي الجوينت يعني above and
لا. If you are using vacuum splint and there is like an open fracture and we splinted that one. I mean, we stop the bleeding. We treat it as an object. Okay. So what we'll do, we'll put a donut, bandage around gauzes, and then we'll apply vacuum splint above, okay? But to try to avoid, put it above the bone because we don't need like any pressure on the bone, okay? So only around, that area is visible. So anyone...
يعني سامحني بتقصد عن الوند نفسه ولا عن الاريا للفراكشر؟
لا الوند راح تغطيه. اوكي سواء open fracture او close I mean sorry open fracture with bleeding ولا بس bleeding حتغطي اوكي بالطريقه اللي احنا تعودنا عليها. وبعدين بتحط لو في كسر حتحط سبلنت. فالسبلنت ما السبلنت فيه لها طرف مفتوح فتخلي الطرف المفتوح مبين فيه الوند مكان الوند الباندج اللي انت حطيته. فما حتسكر عليه كله. لو سكرت كله ما حيبين اصلا في عنده انجري حيفكروا بس ممكن كلوز فراكشر. اوكي ما حيبين.
تمام.
فانت لما تخليه مفتوح بنعرف انه في فراكشر. هاي الرولز مكتوبين. حكينا immobilize one above one below الجوينت. اوكي بنعمل مرات نحتاج يعني we need to pad the splint. حط عليها واحد كبير في العمر من وي رابت we can use like a bandage, anything, okay, to make a band. بتخليه مريح كمان. طيب هنا برجع بالعكس. اوكي هدول هنشوفهم في السبلنتس. طبعا مين هناخذ اللي هو الاسم التجاري اللي هو شو اسمه؟ التراكشن سبلنت. اوكي فيجر. tourniquet already we done. Okay. tourniquet if you have multi-casualty عندك كتير في kind of يعني assault ولا fighting ولا في إطلاق نار. اوكي environment بيكون صعب أنا أركب. عادة في الجيش بيستخدموها عشان السرعة. ممكن عندك severe bleeding cannot manage with normal pressure, you'll go for this one. Okay, hemostatic agent you cannot control, go for that. بتساعد, it will lead for clot formation. Even removal is not easy, but يعني keep it to the hospital. Okay. Extremity trauma. Okay, extremity trauma. Different. Okay. Pelvic binder. كل هذه الأشياء وهذه نفس التيجر سبلنت. الهير سبلنت يعني في لها disadvantages more than one can be يعني it's not comfortable for the patient. Okay, it comes below the يعني في more movement to apply it. Okay, padded بنحط pad مرات or two legs together with a pillow or bed sheet. Okay, we avoid لو في hip fracture or instability. We try to stabilize, stop and stabilize, don't delay. Okay, so below and in different techniques. The one you feel or the patient feels comfortable, go for it. Okay, check BMS, health Seger splint. Okay, depends on the area. Arm slang for less pain. Okay, you can take pictures for this one. Okay, amputation موجود عندنا. Sprain or strain يعني see if you cannot put splint, even this one is good for the patient. The idea is to minimize injury or movement, let's say. So we talk about crush injury, how to do fluids. If you have hyperkalemia, okay, or alkalis. بس ما بعرف إذا في الإسعاف we are applying this one. Sometimes for fluids يعني they are applying diuretics بس إحنا ما ضرنا. Okay, so we don't have only fractures. It's like other kind of dislocations, sprain, strain. Okay, other areas. It's not only bones, even joints. Okay, hips or pelvis. So different technique for splinting with taking care about using safe technique, or let's say the most comfortable for the patient. Okay. Any questions so far?
No, thank you. Clear.
Okay. So let's move for spinal. Spinal is having a big consideration in our practice. Let's go for normal and then abnormal. So if you look here, we studied this one at a stage in our academic life. So if you look here, cervical, thoracic, lumbar, okay, we'll go. So number like 7 cervical, C-spine, we call them, 12 thoracic, and 5 lumbar. Okay, and then we have sacral 5, coccygeal 5. So, and here this one, to protect the spine from like absorbent. Okay. So depend in the area of the injury, we call it like cervical injury, but we cannot detect which one, like 1 to 7. So if you look here, the cord, I mean, it's very soft and flexible like a cotton rope. Here هو weak. ولكن سبحان الله في عنا, we have a protection here surrounded by let's say cerebrospinal fluid. This is one thing, and other the bone, okay, or to make it safe from any force. Okay, so there is some protection, but if you have extra force, there's an injury. So we have a bundle. That bundle consists of nerve. Okay, is having a particular manner, يعني بتعطي وظيفة معينة, function مهم. So we have signals, صح? Sensory signals from body to spinal, and then بوصل للبرين, والعكس في motor response. Okay, وين بتروح؟ إلى المصل. So this is, يعني in general, we'll not go deeply on that one. But if you go for spinal injury, if you are saying spinal injury, it comes like a big problem for all MTs and paramedics, because we are doing our best to avoid minimum movement for the patient. So if you look here, we have hyperextension. If you have mechanism of injury of accident, we are expecting hyper, and when the patient says, oh, I have neck pain, so maybe this one is happened, or falling from high, or diving. Okay, this one's خلاص hanging, roll over, so to the side. So different mechanism of injuries. It's not only spinal injuries, different ways can cause that one. So what is our goal? In real, what we are doing, we are minimizing, we are not providing complete protection. Okay, so what we are using, شو نستخدم؟ collar, okay, board,
spine board,
okay, stretcher. Sometimes we are applying stabilizing the head or neck. So from the beginning we'll go for stabilization. Okay, ask my colleague to stabilize the neck once it's an injury. Inside the car, the same thing. The same thing will go for the Itls for all patients or injured. Okay. So let's say essential components for spinal motion restriction. Okay, again, we are not restricting completely. If you look here, not every patient needs to be strapped into a rigid board, the backboard. I'm with, but again, I need to check my protocols, what we are following actually in the practice. Okay, so some let's say authors or books, they said it's only, or why they invented, okay, to transfer the patient, not transport the patient to the hospital. I mean, transfer the patient to the stretcher. But again, we'll go for what we are having, like an internal protocol. So who is needing that one? We have a criteria, like high speed. We cannot, even the patient is moving and talking to you, as Flas said. Okay, there is tenderness, but he's conscious. But mechanism of injury was hybrid, high energy. Okay, level of conscious. A problem with the nervous system. So we need to stabilize the patient. They are highly advised to do restriction. So the position, we cannot, if you have angulated neck, we can fix to straight that one, be careful, okay? We can use other things, like if you have blanket, if you cannot and it's very, very painful. We cannot make it with alignment. So we can use a blanket, bed sheet to stabilize the head with the same position. Look here for gender, age, elderly or adult, okay, children, where to put it here, because that's is different than the body size. Okay, so what we are using mainly, those things. We have a board for the children, KD, okay, a short board. So all of these we are using, but we are not recommending anyone. Which one is the better for the patient? Okay, the one we are using we'll go for, but with main considerations. Like if there's like an elderly one, we need to pad the board. Okay, be careful if one is having kyphosis. Be careful. It will be so difficult with sores. So it will be sometimes painful. If the let's say, especially maybe in Dhafra, if you are taking the patient from an area which is not a good pavement, okay, not straight or not equal, so it will be so difficult and painful. And sometimes it's difficult to manage the airway, especially for the obese patient. So I need, sometimes I need to move the patient with the board for the position for shock, or move the board with, patient with the board if there's a vomits. Okay, transfer device, not transport device. So it's very traditional method for spinal motion restriction. Okay, we need to log and roll patient, and we'll not forget to shake the back when we move the patient to the side, and avoid moving the patient to the side if there's a fracture or injury to that side. Okay, we need to secure the patient. If it's like a distance between here to the stretcher, so if there's we can give a time to stabilize the patient, it will be more safer. Okay, we'll use appropriate strapping. What do we have? Maybe with the board itself. If you have like inside the building, also we can use it. Okay, so remember that for the airway purpose, we'll start from torso and then go down. Okay, and at the end we'll go for the head. Right. Okay. So different techniques, as we said, we are using log roll. Or sometimes they are using like a blanket to move the patient to the other. Okay, for the section. In all of these, we can take benefit from the board. We can move the patient if he's or she is stabilized well, okay, strapped well with the board. Sometimes we use it for aggressive patient if you have a protocol for that. Scope stretcher. Okay, we have different other devices, vacuum, mattress, but I think we are using scope. So for the scope, when to use it? Did
it's compost by this one.
okay, sometimes difficult to use without the board because of the environment, and pregnant women, I think, easier. Hip fracture mainly, okay, we'll try to use the scope stretcher. Okay, extrication device, we have it. I think we have a practice on that one. So mainly for stable patient can be used, okay, not life-threatening or, for example, an explosion is expected anytime. So because this will take time, more stable patient, okay, but I need to stabilize the back or the neck and apply collar, and then we'll go for that one. Okay. طيب. So emergency rescue, when here emergency, it means, okay, is used only in situation which patient's life is in immediate danger. يكون في خطر because of, like, let's say, environmental hazards. But with caution, it's not only يعني to pull the patient outside of the car. Okay, we can use the blanket. I think there is a way for that, or different. If you go for YouTube, you'll find emergency rescue, different techniques to do that one. Rapid extrication. Okay, so different than emergency rescue. Rapid extrication. We have, for example, airway obstruction. Okay, we cannot do the, for example, jaw thrust to the patient, so we'll go for that one, rapid extrication. We have cardiac arrest. Again, it's life-saving, but at the same time, because of cardiac arrest, I will not push or pull the patient, outside with even nothing, only pulling the patient. Okay, then you will have, okay, if you balance, cardiac arrest is important to do CPR. But again, we don't need more, later complication when survive, but it will be fast. Okay, so this is rapid extrication. If you have hypertension and cannot control bleeding, also we can do that one. Okay, so this statement was supported by many studies, so allowing patients who are able to self-extricate weaning cervical collars may experience less spine motion than. Okay, so we'll try to apply the collar. Sometimes immediately, but we can do the ABC and then head to examination. For water, we are not doing that one. Okay, so different, they are having, if you look to the picture, which is helpful, and for the lifeguards, okay, they have to do that. We can receive the patient from them, and then we can continue. I think they are using different backboard, which can float. Type. Situation depends. We have confined space, it will be difficult, so it's challenging. It's not the same. Okay, we'll try to move the patient, strap the patient with a spider strap, and then move vertically. So with the left, for example, the patient on his face. Okay, so different positions. With the neck here, the collar will make it difficult to, okay, because we have an open wound and the blood is coming out. So we need to control this one. We can use manual stabilization and go for the basics. Okay, use blanket caution, for example. Okay, elderly, again, modify. Use blanket on the board, modify, mixed neutral position. For those, helmet management, I can say that, let's go fast, different types. If you are familiar, sometimes you can open from here, so it will be easy to release the airway. Okay, but remember that if you say, and somebody can say, okay, no need, if the patient is stable, yes, I agree with you. But if you want to give an oxygen, or let's say that you will put the patient on the board, so this one will stuck with the board, and the position will be not straight, not sniffing position, not normal position for the patient. So I need to move or remove that one. Sometimes, for such sport, there are pads here. So with the shoulders, so we have to be aware about everything. Okay, be careful about the nose and the back of the head. So twisting movement is recommended. And here, if you have ring cutter, or we can ask for any such supporting device. Okay. So unstable or incomplete spinal damage is not completely predictable. still we are not doing 100% restrictions. Still there is higher possibility for movement. But we'll try to go with caution. It doesn't mean that the patient is trapped. I will move the patient in different ways. Okay. So we may have special techniques, as we said, based on the, for example, construction area, wherever. And don't focus only on that one, but look for the patient at home. Reassess the airway, still open, patent. Okay, the breathing is good or not. Okay, I need to move the patient with the board. Okay, so all of these make or have a consideration. Any question?
يعطيك العافية.
كثير مستر زاهر.
ما في سؤال؟ يعطيكم العافية.
السلام عليكم شباب.
وعليكم السلام ورحمة الله.
وين والله وصل التركيز؟ وين وصل؟
تركيز في أسفل
بعد الغداء خلاص، بعد الغداء
ضايل منه 10%.
ضايل 10%؟ كيف انتم كنتوا تشتغلوا مع بيشنت واحد، انا جايبت لكم الحين اثنين، شو حتسووا؟
لو خليتونا بدون غدا احسن.
الله كريم الله كريم. اوكي خلاص ان شاء الله we will make it easier. Try to talk to me. هكاك تولوا باقي معناتها ماسكين التركيز. Our lecture it will be for the trauma in pregnancy, and the objective inshallah we will try to understand that we are managing a pregnant trauma patient. It means double goals. Which are these two goals? It means we try to cure the mother and we try to cure the fetus. And we will try to describe the challenges associated with the pregnancy. We will see them almost in general. And we see if the different types of injuries, normally for a pregnant lady or a normal lady, the mechanism of injury, it is almost the same because it is only cause involved from external way. And we try to describe how we can do the initial assessment for the lady or for the pregnant. We will discuss also how can we prevent the trauma in pregnancy. We'll go through them. And as it is already mentioned here, we are talking about challenges. Why it is a challenge? Tell me, why it is a challenge? Talk to me, you will be having more concentration. تطلع لكم 50% تركيز.
ايش السؤال؟
Because we are dealing with the mother and the baby at the same time.
صحيح، لأنكم we are dealing with two bodies. Let us see two human beings. We have a mother and we have the unborn child. This is why it's a challenge. It is not only one patient. We are almost dealing with two patients. Okay, then the major goal here for the pregnant trauma are how to evaluate and how to stabilize. This is our major goals for caring all of them. And all pre-hospital interventions usually are directed towards how to optimize both the fetal and the maternal outcome. This is our aim. We want to optimize the best outcome for the fetus and for his mother. Then, if you do have an optimal care for the fetus, it means there is an appropriate treatment for her mother. This is the gain or the challenge, the unique challenge we are dealing with. And you see, there is a dire rules: provide care to the mother and provide care to the fetus. If you are providing care for the fetus in the appropriate way, it means you are treating the mother in the appropriate way. This is what we are talking about. Now, if we will see the causes, it is almost the same. It's a lady. she's pregnant, she's not pregnant, it is almost the same. The major causes, the same thing. Major vehicle collision, falls, penetrating injuries, burns, might be suicide, homicide, abuse, or domestic violence. It is almost, but here we can say it's statistics are from the ITLS course. It means in United States, but let us see the minor injuries. They're really presenting problems for the EMS experience. We are just in ITLS here, we are focusing on the more severe traumatic injuries to pregnant patient. And the more severe here, we can see that 6 to 20% of pregnancies, they are complicated because it might be an accidental trauma, and sometimes, you know, 2/3 of them are due to the motor vehicle collision. It means the problem, the major problem are the motor vehicle collisions. Almost 2/3. They are the most common cause of the traumatic patients. Here, what are the factors affecting the fetal mortality and morbidity? They're almost the same. If the lady is hypoxic, it will be related to the fetus, okay? If there is an infection, the fetus will be also touched by it. The drug effects, preterm delivery. If it is not on term, of course, the fetus will not be viable. If the lady is not having enough oxygenation, the fetus will not be viable. All these factors that are affecting the fetus. Then, to avoid this affection to the fetus, we have to treat the mother, okay? This is our aim and our goal in this situation. Now, if we are talking about the pregnancy and the fetus, of course, this gestational age of the fetus, if the fetus is less than 3 months, it is already, there is an effect on the lady. The type, the severity of trauma, also the mechanism of injury will be leading to mortal or let us see the viability of the fetus. If there is any disruption on the uterus, of course, it will be also leading to the death of the fetus. All these effects are dealing with both the mother and her child. And why there is a risk, where there is an increased risk for trauma? We can see here, you can read with me here that when the lady is in her early pregnancy, there is a very good increasing in risk of syncope, risk of hyperventilation. There is an excess of fatigue. There is also changes in the balance and the coordination. Almost you can see that the pregnant is often at risk of a higher incidence of accidental trauma. Of course, you can see there is an increase in fainting spells. You can see that she cannot breathe easily. All the time she is like this. There is hyperventilation. There is an excess fatigue. They are all the time associated with an early pregnancy. And of course, the physiological changes, they will affect the balance and the coordination of the lady. In this picture, we can see that there is a fetus inside the uterus or the womb of the lady, okay? Well, how is it important to us to recognize? Because the fetus is formed during the first 3 months of a pregnancy, okay? The uterus does not enlarge very enough of the first 3 months. It is normal. You can see the lady, she is normal, but she is pregnant and she's having a baby, and this baby is still doing he's still be formed during this 3 first months. They say until 12 weeks. This is why we are talking about 3 months. But then when he is fully formed, the fetus and the uterus, they will grow rapidly, as you can see in the picture. And then we will talk about the fundus that where there is the baby. When the fundus is reaching the umbilicus, let us say it will be the 5th month. Here, when it is reaching the umbilicus, we can say that it is 5th month. And when it is reaching the epigastrium, we can calculate it like 7 months of pregnancy. Just to have an idea. The first 3 months, we cannot notice nothing. But there is an embryon, there is fetus is formed. And 5th month, it is reaching the umbilicus. 7th month, it is reaching the epigastrium. Just to have an idea. Then the fundal height is 10 that describes location of the top of the uterus. To have an idea where exactly with this lady. Okay, concerning the 10 and concerning the viability. We can see here a viability assessment, and it depending, of course, of what? It will be depending on the weeks. You can see from the 1st to 12 weeks, it is the first trimester, the fetus will be not viable if something is happening. The lady may be bleeding, she may, the first heart cannot be heard, and of course, the height of the fundus will be difficult to measure, as we said previously. The second trimester, we can see it will be between 13 to 24 weeks. And here, let us see, not maybe in our region or in the Gulf region, but we are talking about United States. It says that in country, maybe well-developed healthcare system, a fetus is considerable, viable about 20 weeks. It means if it's reaching 20 weeks, over 50% survival they are following the delivery preterm. Here we can talk about the trimester. The fetus will be viable, and you can just having a preterm birth. You can even hear the fetal heart, and you can say the height of the fundus. Just to have an idea concerning the viability of the fetus. Now, if we talk about the physiologic changes, okay, if we are talking about the pregnancy, why it is a challenge? We said it is a challenge because there is physiological changes concerning the lady. Are you hearing me, guys?
معاكي دكتورة معاكي.
لأنه في صوت قلت ممكن ما قاعد. Okay. Here we will talk about the physiological changes. What are these physiological changes? We will go through the respiratory system. What is happening to the respiratory system? The uterine size, it will be augmenting, right? Then it will reaching, the diaphragm will be elevated. This is why there is a decrease in the thoracic cavity volume, and this predisposes the lady to hyperventilate. This is why all the time we are talking about rapid breathing or hyperventilation, or the pregnant presents with rapid and shallow respiration all the time, because the chest, there is less chest expansions, and then the pregnant will just do, she will be having a rapid and shallow respiration, which is normal, okay? But it might contribute to other diseases if there is any traumatic injuries, okay? But these are physiologic changes. It means for a pregnant lady is completely normal. What else we do have? The pregnant lady is all the time, we can say she is pale because due to the anemia in pregnancy, okay? Then we are talking about anemia, and there is a decrease in gastric mobility. You know, there is during pregnancy, like I say, dramatic physiological changes occur. And these changes that are unique only to the pregnant state affect. And sometimes they will alter even the physiological response by both the mother and the fetus. Then, if there is something happening here, you can say that more fluid is needed to resuscitate if the patient develops a shock, okay? This is why you have to be aware. Because, as I said, more fluid is needed if you want to resuscitate a patient if she is having any kind of shock, خاصة the hypovolemic shock. Then we can see here all the physiological changes during pregnancy. If we will say the blood volume, it will be increasing 40 to 50. The heart rate also, it will be increased, tachycardia. Blood pressure, it will be decreased. And the gastric motility decrease, If we are saying we do have a tachycardia with low BP, we can say that it might be a sign of shock. But do not forget, these are all physiological changes. This is what all the time we are saying. Do not mistake normal vital signs of a pregnancy for signs of shock. All the time we are saying the same thing, because when we saw low blood pressure and increase in heart rate, increase respiratory rate, we say she might have a shock. But these are normal vital signs for a pregnancy lady, because the normal pulse will be 10 to 15 faster, the blood pressure will be 10 to 15 millimeter of mercury lower, and the blood loss will be 30 to 35% blood loss before any significant changes will be happening. Then this is why be alert to all signs of shock, okay? How can we deal about? By doing the frequent reassessment exam. This is why it is crucial to all the time we have to do this frequent reassessment for a lady. What we say, normal pregnancy vital signs make early diagnosis of shock more difficult because they are all the time the same. What we do have also, if there is any hypovolemia, it might be, of course, vasoconstriction and tachycardia. Then the blood volume or the blood flow in the uterus will be reduced, the fetal heart will be decreased, and of course the fetus becomes hypoxemic. How to avoid all these things? By giving high flow oxygen, 100% to the lady, to the mom. Then this maternal shock, then if something happens, if a shock happens to the mother, then it will be, let us see, 80%, it will be causing what? The death of the fetus. Then start by giving oxygenation to the mother, and when the mother is compensating for early shock with vasoconstriction and tachycardia, he or she is compensated for her body, but it will be impact on the fetus. Then quick review of the shock response and start giving 100% oxygenation to the lady. And then how it will be for the assessment? Normally it will be the same. The ITLS primary and the secondary survey, pregnant lady, not pregnant, it will be the same. What we have to do here, we just optimize maternal and the fetal outcome. As we said, 100% oxygenation, rapidly administered to avoid fetal hypoxia. Okay, and of course, you have to establish an IV and you have to administer fluids. Okay, like this, we will avoid any signs of shock. Optimize maternal and fetal outcome by all the time. We are repeating ourselves. Reassessment and reassessment and reassessment. Any changes, any movement, any changes in the position, or changes in the on the mental status, or on the vital signs, you reassess all the time your patient. Okay, because the mortality of the fetus is related to the maternal treatment. If you are treating the mother in the right way and the right time, you will be treating also her baby. Then optimal care for the fetus, it is the appropriate treatment for his mother. If you are treating the fetus in the right way, you will solve the problem for both of them, the mom and the baby. Now, if we want to talk about the various return, we are talking about the supine hypotension. All the time, the supine hypotension, it is occurring when the lady is just lying on her back. What will happen? She will have an acute maternal hypotension due to what? What do you think?
Increase pressure in inferior vena cava and decrease the blood flow to the heart.
Because, very good, very good. Because of the compression of the inferior vena cava, and if there is a compression on this vena cava, because you see that the uterus is huge. This is why. And this uterus, or large uterus, will compress the inferior vena cava when the mother is in supine position. It will be create a form of mechanical, or let us say, an obstructive shock. This is why, what will be the management here? What will be the management?
Lateral position.
Very
The left
good.
side,
Which
we
one?
define the left side.
left
Yeah,
left
صحيح.
side.
Lateral position on the left. Very good. Yes. The management will be to, during transport, left uterine displacement, either by elevating the right hip 10 to 15 centimeters with a towel, we can put a towel, or if it's possible to manually displace the uterus to the left, I think this will be following your scope of practice. But the simple way to do it is just to put a towel on the right hip of the lady, 10 to 15 centimeters, and you will keep the lady on her left side. If you are transporting a patient on backboard, then you have to tilt or rotate the backboard 15 to 30 degrees on her left side, okay? As they said, do not leave patient on backboard longer. What we said, we were saying it is a transfer, it is not a transport. It will be very good if you have this vacuum mattress for a pregnant lady, but I think till now we don't have this kind of vacuum in our ambulances. Then just transfer and then try to transport her in the right position. The transport position, as we were talking about the transport position, it is better if she's stabilized, as we said, from vacuum backboard. Vacuum backboard is like vacuum mattress. The lady is put inside and we can just inflate this mattress. It is and of course we have to strap the lady, and of course do not forget to place her on her left side. Just to have an idea concerning the effect on the uterine sizes, if it is uterine sizes is less than 20 weeks, we said less than 20 weeks, the fetus will not be viable here, خاصة. But if it is more than 20 weeks and there is a good maternal stabilization, it might be helpful for the fetus, and we will get secondary fetal stabilization, of course. What you can relatively minor abdominal trauma, you said that it is not minor, it is not important. No, this may cause fetal death. And the maternal death is the most common cause of the fetal death. We have to be a very high suspicion here, okay? Even if it is a minor, any abdominal trauma, whatever it is, even if it is minor, it may not significant injury to the mother, but it might be significant for the fetus. Then the management of the maternal injuries is best management for the fetus all the time. Even if it is minor, consider it as a severe because of the presence of her baby. What are the types of trauma?
يعني so دكتورة abdominal trauma not common fetal يعني death not common.
مش على كومن. احنا شو نقول في العاده لما يكون معناتها شيء بسيط، نحن في العاده لما يكون شيء بسيط نقولوا ما في شيء، صح؟ بس بالنسبه للpregnant lady, even if it is minor for her, it might cause a fetal death for the fetus because she might be bleeding internally, okay? And we cannot recognize the early shock for the lady. As we said, we were talking about the physiological changes. لما نحن we delay in the management، هاك الديلاي، هاك الوقت اللي نحن ما نعالجها فيه يكون fatal عشان البيبي. هذا هنا كيف شو نقولوا الميس اندرستاندينج. لما نحن نقولوا اتس ماينر ما في شيء، ما حيسوي شيء، بالنسبه للام ما حيسوي شيء، بس بالنسبه للفيتشس حيكون مضر لي هو. فهمتني ليش؟
اوكي تمام.
اوكي
نشكر.
عفوا. هنا the type of trauma almost the same. قلنا motor vehicle collision هم 2/3 of the cases. penetrating injuries, domestic violence ممكن هم الأجانب كثير domestic violence، الفالز والburns. If we will see the motor vehicle collisions, we are talking about 65 to 75%. أنا قلنا هذول الكل، هذه الإحصائيات تبع أمريكا عشان يحكيوا على نورث أمريكا. نحن إحصائياتنا لازم نسووها عن طريق إدارة الإسعاف. You see here less than 1% injured when minor vehicle damage. But we have to be aware concerning the mechanism of injury. And of course, if the patient is wearing her seatbelt or not, and if it's worn in the proper way, because when we have a huge abdomen, usually we cannot support the seatbelt, and the lady is not wearing her seatbelt because of this hyperventilation and of course this huge uterus, then usually what they do this lap section. Usually it is positioned below the abdomen and over the hips. معناتها الابدومن يقعد exposed. فهمت كيف؟ عشان كده we have to be careful in this situation. Even minor injury, you have to be careful. Then if the lady is wearing her seatbelt on the right way, properly, normally the injury will be less. And here we are talking about the maternal death and the fetal death. Of course, if there is head injury, it is the most common one. It will be leading to maternal death, the hemorrhage, of course, and the pelvis. And the fetal injury will be due to fetal distress or fetal death, placental abruption. These are all when we have the most common death directions on the motor vehicle collision. This is closely followed by an uncontrolled hemorrhage. If there is an uncontrolled hemorrhage, it will lead to a death of the mom and of course of her baby. Then, of course, if you have a maternal pelvic fracture, for the pelvis, of course, we will get a bleeding, maybe more than 3 liters of blood. It is an uncontrolled hemorrhage. We will have a few clinical signs due to this physiological changes, unless there is a high index of suspicion and clear understanding of physiological changes of the pregnancy. Like this, we can deal with. If we have this suspicion and we see that it is a serious pelvic fracture, then here we can assess the mom and of course we will assess her baby. We were talking about the physiological changes. It is almost the same, the physiological changes that we talk about: tachycardia, low blood pressure, and the decrease in motility. We have here decrease in sensitivity because of these changes due to the hormones, due to the what the lady is just, everything is changes on her body. Hormonal changes, and the uterus will be very vascular. As I said, any minor trauma, it will lead to hemorrhage. Then we have to be careful. Even for the response, the rebound response will be absent. We'll not be sure if we do have any abdominal trauma. Then reassessing, checking the patient's changes, blood pressure, checking the respiratory rate, checking the pulse, and maybe might not have abdominal tenderness early because of this rigidity she is having due to the pregnancy. Then we have to evaluate, we have to monitor, and even for minor abdominal trauma during pregnancy all the time, how can we deal this with reassessing our patients? What are the other injuries we can get? The penetrating injuries. It might be a gunshot wound or a stabbing, and it will be different if it is below the phalanges or if it is above the phalanges. If it is below the phalanges, of course, you will see if there is, 40% of high fetal mortality, because it might be just reaching the uterus. And if it is below the phalanges, the one will be dealing or leading to death will be the fetus. There is a lower maternal mortality, 4 to 10%. We can save the life of the mom, but if it is reaching the uterus, maybe we cannot save the fetus. And if the injury is above the phalanges, then we have to think that the bowel injury due to displacement, when the uterus is growing and growing, all the bowel will be going up. And here we have to think to the bowel injuries. Then all the time, definitive care will be depend on the several factors. What are these factors? The degree of shock, the associated organ injury, and of course the time of gestation. This will be helping us to give the definitive care to the pregnant lady. If we have a falls, for example, injury from falls, we are talking about them. There is an increase, of course, if the lady is on the early month, it will be almost the same like for the normal one. But if we are on the 5th or 7th trimester or the last trimester, because the center of gravity it's completely different, then she will get more traumatic, for example, extremity trauma or even head or pelvic trauma. Then it will be proportionate to force and the body part impacted. Okay, the height and where she was, the distances between her and the fall. We might have pelvic injuries, of course, fetal fracture or placenta separations due to the force. Concerning the burns, almost it will be the same for a normal one. But here, we'll talk about the fluid volume. We have to give it very early. We have to take an IV very early. As we said, the maternal mortality, she's pregnant, non-pregnant will be the same. It is because due to the burns. But here, if the burns surfaces is more than 20%, then there is a very high risk for the fetus. Then it's required, as we said, 100% oxygenation. And of course, we have to take an IV, and we try to replace all this fluid volume to the pregnant lady. The first exam, we were talking about it during our assessment. This is the sonography in trauma. It is very useful when we have a long distance, or if we want to do our assessment on the right way. There is a rapid assessment to see the free fluid. Is it blood or is it only liquid? If it is perihepatic space or perisplenic space or in the pericardium, it will give you a right idea concerning the cases, if it is due to which kind of injury. Okay, and of course the fast exam, it can determine if the fetal heart rate is slow, then you will provide 100% oxygen to the mother in order to treat the fetus. The fast can assess also the fetal heart in a noisy environment. If you cannot hear the heart rate, for example, if there is a lot of noise, if you have the fast, it will be helping you to detect if there is any heart rate on the fetus. It means this is an effective way to assess both mother and fetus, as they said. And of course, as they said, you can assess the fetal heart rate, and of course, to make the right decision, even if you don't have the fast, as we said, after the initial assessment, you do your airway, you check their breathing, give 100% oxygen to the lady. How to prevent trauma, even if she is not pregnant? Proper seat belt is used for everybody. If there is any domestic violence and you check the lady, she is complaining, you have to report this. Counseling, if you report this, and if there is a specialized center to do this, to do counseling for domestic violence. And patient education, how can we educate the patient? This will not be done by you, but you can advise her after that. For our job in the pre-hospital care, we just came there to prevent any fetal death or maternal death by giving oxygenation, by taking an IV, by giving the right treatment or the right management, and by year assessing, and what also by taking the patient to the right place, the right hospital, without delaying, without taking our time on the scene. Okay. And in the summary, trauma in the pregnancy, as we said, knowledge of the physiological changes will be very helpful, because we are talking about this hypotension and hemorrhage easily overlooked. We are thinking, this might be a shock. It is not, but treat a lady. rapid evaluation, interventions to stabilize. If there is anything, you give aggressive oxygen administration. It is aggressive, it is not. You give 100% oxygen. You also give fluids to the lady. Prevent supine hypotension by putting the lady on her left side. And of course, do not forget that fetal care depends on the maternal care. Do you have any questions, guys?
دكتورة بس عندي سؤال. حكيتي إنه إذا كان عندنا 20% بيرن بريجننت فيس، تقصدي الفيس نفسه ولا البادي؟ يعني 20% من الفيس؟
اللي كل البادي كامل.
من
إذا
البادي
20%
كامل.
أيوة من البودي سيرفيس اريا. البي اس اي هو البودي سيرفيس اريا. إذا كان أكثر من 20% هذيك لازم رابيد ترانسبورتيشن لأنه ممكن يضر بالفيتشس.
تمام، بارك الله فيك.
تمام، يعطيكم العافية.
الله يعافيك دكتور.
يعطيكم العافية يا شباب. شكرا دكتورة. إن شاء الله بنشوفكم بكرة صباحا 8:30 في كلية فاطمة إن شاء الله.
إن شاء الله.
ختامها مسك معناتها.
أي والله ختامها مسك صحيح يا دكتورة، بارك الله فيك.
حبيبي يلا يعطيكم العافية.
جزاكم الله كل خير جميعا.
نراكم على خير.
مع السلامة. السلام عليكم.
يعطيكم العافية.